Hello, good afternoon. Oh, right. Hello. Am I audible to you guys? Hello. Can you hear me?
Yes, sir.
Yeah. So we're starting with the toughest topic in MRCP, that is cardiology. I don't know why it becomes very difficult to achieve a very good number in cardiology. We'll give a good exam. I'm sure about that. But after what I mean that when the result is published, you'll see that uh, unfortunately maximum of the candidates, they are doomed in cardiology. I don't know why. It becomes very difficult to achieve a very good number or a healthy number in cardiology. One of the reasons behind this, that in maximum times what it happens in the exam scenario, you're suspecting answer to be correct, but eventually it is a wrong answer to them, because all the five answers regarding the cardiology section seems very correct, okay. So reason why I'm saying that it is very difficult to achieve a very good number or healthy number there in cardiology. Most importantly, what happens in MRCP part on that candidates, they expect that questions would be coming from different type of arrhythmia, question might be coming from the ischemic heart disease or any sort of valvular heart disease. But when you enter the room and you got the question paper, and after when you open the question paper and you can see that the first question from the cardiology, or even the first question is coming from the atrial myxoma, so it makes the whole scenario very difficult for you guys, okay. So as I'm saying, you have to take this cardiology very seriously if you want to achieve a very good number. Another thing, cardiology is somehow, what I found in my observation, that cardiology is more easy or easier than the other subjects there in paces, because you know that in cardiology the case should be the case should be a valvular heart disease, okay. So it might be a mitral valvular heart disease, or it might be a aortic valvular heart disease. Yeah, sometimes it's a mixed valvular heart disease, and then it becomes very difficult for us to make the diagnosis, okay. Like you can see the patient is having some sort of uh, what I should say, like the patient is having a collapsing pulse, and of course a high volume collapsing pulse, and you can see the patient also is also having a widening of the pulse pressure. And of course you have appreciated calorie dancing in the neck. So you're thinking this might be a case of the aortic regurgitation. But when are you going to auscultate the precordium, now you're in danger. Why I'm saying you're in danger? Because in aortic regurgitation, it was supposed to be a murmur of the early diastolic murmur. Well, now you're very confused. Why? Now the fast heart sound is very loud. So now you know that when you're getting the fast heart sound very loud, so it does mean the patient might be having also a mitral stenosis. Yeah, and now if you're appreciating a murmur like the MS, I mean the mid diastolic murmur, so as you know, there is a murmur already existing murmur like the early diastolic murmur, and now you're going to appreciate another murmur that is supposed to be a mid diastolic murmur due to the mitral valvular heart disease or mitral stenosis. And somehow, suppose you're very confident, yeah, this is a mitral valvular heart disease and this is a mitral stenosis. Suppose mitral stenosis, again you're being very confused because you're getting high volume collapsing pulse, and of course a carotid dancing with a high or widening of the pulse pressure. The reason why you're going to say, yeah, this is the case of the aortic regurgitation or aortic valvular heart disease anyway. But after finishing the exam, if you think it was also a case of the mitral valvular heart disease, and it was a MS, case of the MS, even if it was a case of the CMS. So you know, if you cannot appreciate the both valvular heart disease, or if you are diagnosing or if you're going to diagnose only the half of the case, so you know you're going to also get half of the case. It does mean you're not going to be paid the full numbers by the examiners. Reason why I'm saying, Yeah, it's easier to achieve number in cardiology over there in paces, but not that much easier. Don't take my statement in that easier way. Okay. Again, there are some other murmur will be very confused regarding the murmur of ASD or murmur of VSD. Even if unfortunately, suppose you have got a case of the pulmonary stenosis in your case, yeah, one of our candidate got the case pulmonary stenosis, so the situation would be horrible to you. Okay, but I hope you guys are very talented doctors and you will do the best in your life as well. But now focus on the MRCP part on. Now focus on the MRCP part on highly, because in MRCP part on and in MRCP part 2, both in cardiology, I mean both in part 1 and both in part 2, it's very difficult to achieve a healthy number. I'm not saying it's difficult to pass in cardiology, but I'm saying it's difficult to get a healthy number there in cardiology. So it will be my recommendation to you guys to follow my instruction, that how I'm saying all these things together, or how I'm giving the clues, or I'm giving the ideas that how you should get your diagnosis, or how you can cleanse the diagnosis. Okay, so just follow my recommendation or follow my lectures, that how I'm going through all these topics. And don't forget that you need to also solve the past test, and of course you need to solve, just a minute. Okay, and also you need to solve the question from the on exam if you're getting enough time in your hand. If you don't if you do think that you are not having enough time in your hand, then at least, or the least you can do, that is you have to solve the past test. Okay, now as you can see here, there are some topics overview, and if you're I'm going to give you some of the important topics from here. Then the ECG might be a 5-star topic there in MRC part 2, but somehow ECG isn't that much important like the others. Okay, because as you know, in MRC part 2 you'll be given some pictures of the ECG, and almost 8 to 12 ECGs would be there, and they're very difficult to make a diagnosis. But I think it would be very easier for you guys if you are following the protocols, if you're following the instruction by us. So questions from the ECG, yeah, there will be some question from the ECG, but you will not be given any picture of the ECG, rather you will be given some findings, and from there you have to make the diagnosis. So don't worry about that. I will give you the idea that how we're going to make it happen. And after that, it was very important to know about all the pulses. But if you are making any mistake in the pulse, so you know that you are going to also miss the case. So it does mean you have to focus on the pulse rate, pulse rhythm, volume, the character, asymmetry, or any sort of delay, and of course whether there is any given BP, and what is the nature of the BP, whether it is high or low. What about the pulse pressure? Okay, you have to know all the things together. And after that, the precordia, I mean the heart sounds, what is the nature of the first heart sound, what is the nature of the second heart sound, whether there is any sort of split in between the second heart sound. As you know that second heart sound, it has two components. One is the aortic component and another is the pulmonary component. Now let me give you a clear statement, please don't mind. If you do think that in that way, that is very difficult to appreciate the split of the second heart sound. My dear doctor, listen to me very carefully. This is a post-grad exam, so don't talk as like the undergrad doctors as they talk. Okay, so don't assume that you are an undergrad doctor, you are already a postgrad doctor, you're doing post-graduation. So you need to know that what is split. You need to appreciate this split if it's happening in the patient, right? Like you've got a case of the ASD, I mean the atrial septal defect, and now you don't know that what is the split or what is the fixed split, on whether there is any sort of split or not. So you are not going to make any diagnosis, because it's very difficult to make a diagnosis of ASD over there in clinical life, I mean in PACES exam. Okay, so if you don't know about this split, so it will be very, 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 very difficult for you to make a diagnosis or make a confident diagnosis regarding the atrial septal defect. So if you do think in that way, well, somehow I will make some differentials and I will tell the examiners regarding my differentials. No, it's not that easy a way. Okay, so you have to know regarding even the split. I mean whether there is a normal split, when there is a widening of the split, or any reversal of the split, or any fixed split. I mean, if there is any abnormality, then you need to appreciate that, and of course you need to focus on that, and you have to make a diagnosis after considering this sort of splitting problem. But After that, you need to know about the heart sounds as well, like the first heart sound and the second heart sound. What's the nature of the first heart sound, or the nature of the second heart sound, whether there is any info regarding these given or not. Well, like if you are going to make a diagnosis of the MS, and if you think the heart sound isn't that much loud, okay, so you have to consider the MS again after considering the others, right? So why I'm saying this, because in MRCP part 1 or in MRCP part 2 exam, the first heart sound should be loud, as they are giving you the statement. As you know, this is a dummy case in MRCP part 1 and part 2. You know, these all are the dummy cases. I mean, maximum cases they are not the real cases. So they will give you the clear-cut idea. Yeah, the patient is having a heart sound, first heart sound that is loud. It doesn't mean it might be case of the MS. Okay, in practical life, so many MS patients you might see the patient the first heart sound isn't that much loud, or you are not supposed to say, yeah, the first heart sound is very loud. Okay, so having a normal first heart sound, the patient might also have a mitral stenosis. It's possible, it's really possible. Again, if you are thinking, yeah, you need to make a diagnosis of the mitral regurgitation, and if you do think, yeah, they are giving you the first person is loud, the first one is normal, so this is not a MR. So this is not a case of MR. In MR, if this is a case of the mitral regurgitation, then the first heart sound shouldn't be loud. Okay, shouldn't be loud. Okay. So again, in case of aortic stenosis and aortic regurgitation, you know, there are some changes of the second heart. So we will talk about that when we are going through this and this. So to talk about that. Now, jugular pulse pressure. Again, I'm saying the jugular venous pressure. It is again a very important talk in MRCP, because in MRCP part 1 will be given some questions from the JVP. In MRCP part 2, definitely will be given some question from the JVP. And what it makes it most important, that they are in PACES exam. Like, you will be asked when you say, yeah, the patient is having elevated, or when you will say the patient the jugular venous pressure is elevated, then the examiner will ask you that, have you appreciated any sort of waveform? I mean, do you want to say there is any particular waveform, like the A wave, like the V wave, or is there any sort of descent you have appreciated, like the X descent or the Y descent? So ultimately, what they were asking, they're assessing your depth of knowledge. If you are saying, sir, I'm sorry that I couldn't appreciate any particular waveform, okay, that's fine. But if you are asked in that way, what is a wave, and when you will appreciate a wave, when you will consider a wave, what about the X descent, what about the Y descent? And you are saying, sorry, sir, I forgot, somehow I unfortunately forgot the answer. So no, then you are not going to pass the exam, whether it is you are in a potential space to fail the exam. So you know that. You have to know each and everything regarding the jugular venous pressure. Okay, each and everything. Infective endocarditis, again I'm saying, if you follow the recent recalls, then you will find that infective endocarditis is the hot topic of MRCP exam in part 1, part 2, even in PACES. Like in my PACES, in my PACES experience, my station 4 in the old system, as you know that I passed the exam in the old system, and now you guys are following the newer update or newer version of the PACES exam. So in my time in station 4, I got a case that was a infective endocarditis. Okay, there was a case of the infective endocarditis, and I was asked each and everything from the infective endocarditis, each and everything. Okay, each and everything. And somehow I forgot to say something very important. I can't even remember that what I forgot over there to say to the examiner, or to tell the examiner. But I lost some numbers, and that is what, and the numbers were in the station 4, and that was a case of the infective endocarditis. And other than this station, I got full marks in every station. So as you know, you can know that it's very important to know all about the infective endocarditis. Okay, each and everything. And I was asked about the details of the antibiotics. Okay, how I will give the antibiotics, what are the changes of the antibiotics, when the antibiotics will be changed, and what we do follow as per the local guideline here in our country. I was asked even this question. Okay, so I'll give you some idea. Oh, another question I was asked: suppose a patient who is having heart issue or valve issue, and you're suspecting, or the patient is already diagnosed with infective endocarditis, and somehow now the patient wants discharge against medical advice. Why I'm saying this? Because you know that in infective endocarditis, the patient will need antibiotic coverage, and for that is almost 4 to 6 weeks. Okay, it's a long-term hospital admission, and patient won't be that much comfortable to be admitted in the hospital. So the patient will ask you, doctor, can I take this medication in my home? Okay, so then you will have to enroll the patient with the district nurse or the city nurses. And I was asked this question, that how will give the antibiotics? Will you switch to any oral form, or will do anything for the welfare of the patient and for the justification? So actually they were assessing my death, not my death, rather they were assessing what is my concern, what is my judgment, what is my welfare, what is my decision to for the well-being or the welfare of the patient. Because as you know, in PACES they assess these things separately, and you need to pass these kind of sectors or these kind of areas separately. Suppose you in science, in sign or in symptoms or in history taking or in making a diagnosis of the differentials, you have passed each and everywhere, but somehow you're one number you are lacking. So you mean you are cumulatively you are failed. So you know that it does matter a lot. Okay, so you have to know each and everything when you are going to pass the MRCP exam. If you are not considering MRCP exam, so I will say I will recommend you guys not to follow these things in that depth. But if you're considering the MRCP exam, you have to focus on the NSH system, you have to focus on the British or the UK system, that what they actually do over there, and you'll be asked regarding those questions even in the MRCP part 1, MRCP part 2, and definitely in the PACES. Now about the valvular heart disease, that's most important in MRCP part 1. So a lot of questions that will come from the valvular heart disease: aortic stenosis, angiodysplasia, aortic regurgitation, Marfan, osteogenesis imperfecta. You can see that a lot of questions. So what it happens in MRCP exam, if you're somehow, if you're like you've got a case of valvular heart disease, and you always do think in that way, like the patient might be having any rheumatoid heart issue, rheumatoid heart disease, like the examiner will ask you that why do you think the patient is having any this sort of mitral valve issue or aortic valve issue. So in our observation, what we have found, that maximum candidates, they want to say it might be a case of the mitral valve heart due to rheumatoid heart disease. And as you know, this is the most common thing across the globe. But regarding MRCP exam, you need to consider what I should say, like you need to consider what about the patient, I mean the physical look of the patient. If you think the patient is very long and tall, okay, so then you have to consider the Marfan. In maximum cases, particularly if you're going to appear the MRCP exam in India or even in Bangladesh or even in UK, so Marfan syndrome is very common over there. And if you cannot make the diagnosis of the Marfan syndrome, but somehow fortunately you have diagnosed the case of the mitral valvular heart disease or the aortic valvular heart disease, no, doesn't even matter. You need to know, just a minute. So you need to know about all the things about the Marfan syndrome as well. Okay, so be careful regarding this thing as well. Another thing that is also important in here, not here, rather we can say regarding congenital heart disease. Okay, now the congenital heart disease, the types, the atrial septal defect, the Eisenmenger syndrome, or the PDA, patent ductus arteriosus, or even some cases of the Down syndrome, the features. Down syndrome is very important in MRCP part 1 exam. And patent foramen ovale, from here you will be asked some questions regarding the paradoxical embolization or not. I mean, if you appreciate a new stroke or young stroke, then what I have said, I already have told you guys in our previous neurology section, like if you can see the patient is having a stroke and the age is very, very young, and particularly if the patient is female, you need to consider, as you know, the antiphospholipid antibody syndrome. Again, you need to auscultate the precordium, whether the patient is having any sort of mitral valvular heart disease, reason why the patient might develop any sort of emboli, okay, or any thrombus. Or another thing you need to be very careful regarding this, another chance that might be the patient is having any paradoxical embolization or not. Yeah, the other things, it's very important, you have to also exclude all the vasculitis, particularly the Takayasu vasculitis or Takayasu arteritis, that is very common in MRCP part 1 exam, part 2 exam, even in PACES. So many cases are there over there in India, here in Bangladesh as well. Okay, so now the TOF, that's also very important. Evistin anomaly, I think this case is now becoming a hot topic for MRCP exam, for FCPS exam, for MD cardiology exam, every sort of exam. Evistin anomaly is now a hot topic. Another thing that you need to know was that is the Holt-Oram syndrome. That is a Holt-Oram syndrome. Why I'm saying this? Because you know that in recent PACES exams, some cases of the Holt-Oram syndrome, particularly in the center of the Kolkata, they are giving some cases of the Holt-Oram syndrome. So if you are going to appear the exam, the final exam over there in Kolkata, and you've got the case of the Holt-Oram syndrome, and suppose you're in a big problem, you cannot make the diagnosis. So you know that it will be very difficult for you to pass the exam, because in cardiology section you must pass the exam. So Holt-Oram syndrome is not included here. Reason why I'm saying this, you have to know about the Holt-Oram syndrome. Actually, the patient will be having atrial septal defect. The patient will be having some mental defect. I mean, the patient will look like a Down syndrome patient, okay, and the patient will have polydactyly. So if the patient is having all these things together, please consider the Holt-Oram. I'll give you a detailed idea after this section. Now also we have to go through the arrhythmia, but arrhythmia is not the topic of today. We'll start the arrhythmia section in the class 2. Now we'll jump onto the first topic, okay? And if you do have any questions regarding our class today, then please feel comfortable to ask me any question. But I think all the questions, those are important in MRCP part 1 exam, or that is regarded with MRCP part 1 exam, will be answered eventually when I'll go through the classes or go through the topics. So the CAP, that is the cardiac action potential, that is also very important. You will be asked some questions from this CAP in the MRCP part 1 exam only. This topic is not that much important in MRCP part 2, and in PACES you know that it carries no significance. So as you know from the physiology, I mean the heart physiology from the first year, I mean when we were in the medical school, it has some 5 phases ranging from O to 4. I mean the phase 0 or O, that is the rapid depolarization. While the patient is having rapid depolarization, that is the rapid sodium influx, and these channels automatically deactivate after a few milliseconds. Then the phase 1, that is the early depolarization, that is the efflux of the potassium. The commonest question from this chart actually, that is the why the patient will be having the plateau phase, that is a slow influx of the calcium. And if I'm not wrong, that is also a very common question here in FCPS part 1, or even any sort of entrance exam of a residency or diploma here in Bangladesh as well. So as you know, this is a very basic question, so you shouldn't miss this question. And in phase 3, in final depolarization, there might be some efflux of the potassium and restoration of the ionic concentration. You have to know these and these. So now the conduction velocity is, you know, the atrial conduction, what is the rate about that, like the 1 meter per second, and AV node conduction 0.05 m per second. And in ventricular conduction, you can see the Purkinje fibers are large diameter and achieve velocities of 2 to 4 meter per second. This allows a rapid and coordinated contraction of the ventricles. Now the ECG and the normal wave, that's very, very important, and that is a very highly paid question in MRCP part 1 exam. Like if you think the following ECG changes are considered normal variants in the athlete, so it will be asked regarding ECG change of athlete, and the commonest thing that is asked in the MRCP exam, like the heart rate, why the patient is having this type of heart rate, whether you will consider atropinization of this patient, whether you will consider temporary pacing of this patient, might be percutaneous or might be transvenous, like in this way. But no, in athletes the patient might have sinus bradycardia, but always I do say, if you are asked in that way, if the patient is having ECG changes and that is only sinus bradycardia, okay, that's fine. But the patient is athlete and the patient is also having a chest pain, and you can see some changes in the inferior leads, and the now patient is having sinus bradycardia, no, that's not physiological, there's something bad. So then you need to consider atropinization. If atropine is not giving some sort of symptomatic relief, or again if the patient is having bradycardia or the heart rate is very minimum, then you have to consider the temporary pacing, as you know. And if you can see the patient is not having any P wave and the patient is already an athlete, so might be a case of the junctional rhythm, okay, a junctional rhythm. The patient also might have a first degree heart block, or might be a Mobius type 1 heart block, that is the phenomenon, okay. Now the ECG and the coronary territories, that is also very important in MRCP part 2 exam, because in MRCP part 2 exam you will be given some pictures of the ECGs or some echoes, okay, and from there you need to make the diagnosis. Again, in MRCP part 1, as you will not be given any sort of images, so it would be in a written form, like the patient is having ECG changes from ranging from V1 to V4. So you know that if the changes are the V1 to V4, there might be some anteroseptal involvement, okay, and the involved artery might be the left anterior descending, I mean in the LAD, okay. So anteroseptal does mean LAD, and the ECG would be the V1 to V4. If you do think the changes are the 2, 3 and AVF, then you need to consider the right coronary artery. Again, I'm saying, if you do think they are giving you some data regarding the inferior changes, then you have to focus on to the other things as well, whether the patient is having any sort of dizzy feeling or not. What about the vertigo? What about the syncope or the pre-syncope association, whether there is any sort of association or not, okay. Another thing that you have to be very careful, very careful. What's that? Can you see me? Yeah. Okay, I think now I'm audible and visible again. Okay, so if you do think the patient is having any inferior changes, I mean in ECG they are giving you the data, I mean the patient is having the patient already was suffering from some chest pain for this duration, and on the emergency department the ECG shows changes in lead 2, lead 3, or even in the lead AVF, okay. Then you have to consider also the pulse rate, very important in inferior changes, inferior MI, okay. You have to consider the pulse rate. What is the pulse rate that's given, okay? What's the pulse rate that's mentioned in the question? Whether there will be any need for atropinization, whether there will be any need for temporary pacing, or whether there is any chance of developing complete heart block. As you know that inferior MI is somehow related with the complete heart block, okay. Now if you have checked this, okay, no, now patient has no chances of the complete heart block, or there is no association, or there is no chance of having this type of problem, then you need to focus on the other thing. What's that? There is the V1 and V2, okay. If you do think that the R wave is taller in V2, so you know there is also the posterior extension, okay, in posterior extension. And if the patient is having inferior MI with posterior extension or posterior involvement, then you need to know all the ECG criteria of the posterior involvement. You need to know the importance of giving fluid to the posterior involvement or the posterior MI. As you know that in posterior MI or the posterior involvement, we need to give some sort of fluid to the patient, okay. Now in inferior MI, why the patient will be having high chance of developing complete heart block, because in inferior MI it's supposed to involve right coronary artery. And as you know, the right coronary artery, it has a 60-90 rule. What I'm saying, the 60-90 rule, SA node is supplied almost 60% by this right coronary artery to the RCA, and in AV node that is almost 90% supplied by the RCA. So if RCA is somehow occluded, then high chance of also malfunction, there is also high chance of malfunctioning for the SA node or the AV node. Now what about the anterolateral? So why I'm saying the anterior and lateral, okay, you can see the changes of the AVL or the lead 1, or also V4 to 6. So that is the anterolateral. So left anterior descending or the left circumference might be involved. If you do think the changes are only in the lead 1 or the AVL, not in the V4 V6, then that is the high lateral. So it's not like that all the leads together will be involved. I mean, you might see the V4 to V6 is absolutely normal. So the changes in the 1 or changes in the AVL also might carry some high significance of having anterolateral MI, okay. So also consider this one. Now what of the lateral MI? So lateral MI, as I've said it, if there is changes in the V1 lead 1, or in changes of the AVL and the plus minus V5 to 6, then you know that in lateral MI we will consider the problem in the left circumflex. What about the posterior MI? That is very important. As I've said it, in maximum cases you will see there are some tall R wave in V1 to V2, actually in the V2. So in posterior MI there will be a tall R wave in V1 to V2, And yeah, in posterior MI, usually the left circumflex is usually involved, but also right coronary artery might be involved. But always consider, as you know, that in posterior MI, if you are going to consider a posterior MI or a posterior extension, you need to focus, or you need to see, or you need to know about the T wave. Okay, about the T wave. The T should be upright here. Okay, the T should be upright here. As you know that in MI, sometimes the P might be flat, okay, or might be some depression, okay, and might be and often you will see, of course, the negative deflection as well. But in case of posterior MI, the T should be upright. Don't forget this one. This is a very important clue for making a diagnosis of the posterior MI or the posterior extension. That's very important. Now the axis deviation, that is also very important in a MRCP part exam. From here, you need to know about the left axis deviation. So from my recommendation, if I'm going to give you some recommendation, yeah, this one is highly important for you, or this one is must important for you to know about this axis deviation. One was that the main two, I think, which might fall you in danger. That is, number one is the left anterior hemiblock, LAHB. So left anterior hemiblock, the number one thing that might come up with the left axis deviation. And the another one, that is, if the patient is having accessory pathway in the right side. Okay, it does mean, the accessory pathway does mean the patient will be having a delta wave and pre-excitation issue. So we are calling it the old Parkinson-White syndrome, WPW syndrome, you all know. So if the patient is having any WPW syndrome, and also that is the accessory pathways are in the right side of the heart, so there might be some left axis deviation. The other things what you need to know, that the left LBB, very common, but in exam purpose, that's not that common. The left anterior hemiblock and the old Parkinson-White syndrome is more common in MRCP exam. The changes in hyperkalemia, or some in ASD cases like the ostium primum ASD. Okay, so, and the tricuspid atresia and minor LAD in obese people. So in obese people, LAD is a common finding. And in my time, I was asked regarding these things. Okay, and the patient, I was asked why the patient is having left axis deviation, and the answer was simply obesity. The answer was simply obesity. So that it carries also some high significance in MRC part on exam. Now the cause of the right axis deviation, well, the patient will be having right axis deviation if the patient is having right ventricular hypertrophy, or the left posterior hemiblock, or some CLD cases. I mean, CLD does mean the chronic lung disease like the cor-pulmonale or the pulmonary embolism, or the ostium secundum ASD, or old Parkinson-White syndrome, that is in the left side accessory pathway, and even normal in the infant and normal in the tall people. So what it happens, some of the candidates, they use some mnemonics to know these things together. Please don't do this, because in MRCP exam, the more you are accustomed with mnemonics, the more danger you are going to fall. Okay, so always remember this word, that you don't all the time. It's not necessary to rely on the or to depend on the mnemonics all the time. Just let me pick a phone call. হ্যালো, হ্যাঁ বলেন, আমি যে ক্লাসে তো। Okay, so sorry for the interruption. So what I'm saying, please don't rely on the mnemonics all the time. It's a normal finding. Like there might be some right axis deviation in the tall people, and in infant there's a normal finding. In WPW syndrome there will be some, as you know, the left-sided accessory pathway, and the patient might have some right axis deviation. Okay. And in ostium secundum ASD, so you can see, now you can see both in case of ASD, if that is a OP variety, so there might be some LED. Okay, so you know the OP with the LED, so we used to call it the OPLAD. Okay, or OPLAD, what do you say from your side, doesn't matter. And ostium secundum, that is the OSASD. So if you know the OPLAD, so it becomes very easier to know the other thing. So you have to focus on this thing as well. But as I've said it, that the question will be from the WPW syndrome. Okay, so in WPW syndrome, you can see that if the patient in WPW syndrome, what syndrome, the patient is having left-sided accessory pathway, so there might be some right axis deviation. Why I'm saying this? Because you know the pre-excitation, so from the left side is working very fast, from the left side is working very fast. So eventually the right side that's not working very fast. Okay, so there might be some changes, or might be some axis deviation. I mean, might be some muscle hypertrophy, as it has to work from with its own muscle, not getting enough power from above, or not getting enough stimuli from the different pathway as the left side is getting. Might be that there's another reason. Now what about the ECG? As you know that the intervals are very important. The QRS, the PR, the QT is very important. So now we have to know about the fast degree block or the prolonged PR interval. Okay, so we will be given many cases for the PR interval, but the fast one was very, very important in the MRCP exam. I must say that is the aortic root pathology. So this one is the highly important, the most important thing to know about. Okay, so aortic root pathology is very important. So first degree heart block is normal. Okay, even in athlete you might see there is a PR prolongation. It doesn't mean that he or she is having first degree heart block. This is a normal variant. But if you're suspecting a case of the infective endocarditis, and if you can see there is the PR prolongation, so you know the patient is in danger. It's not a simple thing. There is the aortic root pathology. It might be abscess due to the endocarditis. So that's very, very important to know about. Then another thing that you need to know, that is the Lyme disease. So these two is highly important for you guys to know about from the PR interval. Yeah, there's some other reasons again. Was that like the idiopathic, might be due to the ischemic heart disease, most common finding in clinical practice, like maybe due to the drug issue, like in case of drug like dioxin. Might be in the case of the hypokalemia or the rheumatic fever, or in sarcoidosis or the myotonic dystrophy. And a prolonged PR interval may also be seen in athletes. It's a normal finding we have already discussed about. So a short PR, was that a short PR does mean a pre-excitation, and for the MRCP exam, if you're considering any sort of PR excitation, pre-excitation, then of course it's due to the WPW issue. So old Parkinson-White syndrome. They're saying the hyperkalemia even rarely cause a prolonged PR interval, but this is a much less common association than the hypokalemia. Okay, that's a good thing. Now the complete heart block. So complete heart block, you know, when there is no gross association between the QP and the QRS complex, but somehow the QRS complex and interval are normal in between them. So then we are going to consider a case of the complete heart block. But before making a diagnosis of the complete heart block, you need to consider the underlying clues. Why the patient is having complete heart block? Might be a case of inferior MI or extensive anterior MI. Reason why the patient might have complete heart block. So you know the ischemic heart disease is one of the potential causes. Another thing what you need to know about, whether the patient is having any drug issue. Whether the patient is having any drug issue. The third issue is that whether the patient is any infiltrative issue. Might be sarcoidosis, might be in thalassemia due to the iron overload. That's very important in MRCP exam as well. So if you're going to consider a complete heart block, then how you will have the idea, yeah, the patient might be having CSB or the complete heart block. So there should be some dizzy spell. Okay, there should be some dizzy spell or lightheadedness followed by some syncope or pre-syncope. What happened? It might differ from your cases. So heart failure, yeah, the patient might also have some features of the heart failure, and the patient will be having regular bradycardia, and there will be some wide pulse pressure. In complete heart block there might be some wide pulse pressure. And in JVP, cannon waves in the neck. Okay, so in JVP, cannon waves in the, that's very important, the cannon waves in the neck. And the fast ultrasound, the variable, the intensity is variable. So if you can see, they're saying that the fast ultrasound is variable in intensity, then you have to consider whether this is a case of the complete heart block, or even might be in case of the mitral stenosis. Okay, in mitral stenosis, the patient might be having a loud fast heart sound, but also there might be some differences or some variability in or some what I should say, some changes in the fast heart sound as well. It's not always that the patient will be having a very fast or very loud fast heart sound. Okay, so you have to also believe in this. So now the types of the heart block, we'll consider the fast degree heart block if you can see the PR interval is more than the 5 small squares. I mean, it does mean it is more than the 0.2 seconds. As you know that 0.1 to 0.1 to 0.2 seconds, that's normal PR interval, and if it is more than the 0.2 seconds, they will consider the PR interval. Okay, so I mean the prolonged PR interval, that's due to the fast degree heart block. What about the second degree heart block? It might be a Mobitz 1, we'll call the Winspeck phenomena. And what's that? There may be some progressive prolongation of the PR interval until a dropped beat occurs. That's very important. There will be some progressive prolongation of the PR interval until a dropped beat occurs. And again, the cycle will repeat. And in type 2, we'll call the Mobitz type 2. There is a PR interval is constant. We'll see the PR interval that will be the constant, but the P wave is not often followed by the QRS complex. And don't forget, here the interval between the QR complexes will be variable. Reason why this is not a case of the complete heart block. So you know the type 2 or Mobitz 2 heart block looks like the complete heart block. So treatment policy is also very similar in between these. I mean the Mobitz type 2 and the complete heart block. Okay, the patients who are having Mobitz type 2 heart block, they will have high chance of developing the complete heart block. Now the third degree of the complete heart block, that is there are no association between the P waves and the QRS complex. So what I say, if you do think there is no association, I mean if you see this is a gross atrioventricular dissociation, then that might be case of the complete heart block. Now there are some the changes in left bundle branch block, I mean the LBB and RBB. So there is a common practice and common rule to rule out this kind of LBB or RBB. As you know, in recent times, LBB or left bundle branch block is very important, because the new variant or the new onset of the LBB is almost equivalent to a stale-variant MI. So it's of course very important. Well, so if you're going to consider a case of the LBBB or RBBB, then you have to know the William marrow. That will help you to make a diagnosis. So as you can see, the William marrow. What's that? If you're going to see in LBB, so in LBBB there is a W in V1 and M in V6. Okay, so if you think there, like in this case, okay, you can appreciate a M in the V6, and you can appreciate almost a W if you are going to consider it as a W. I mean, if you're going to see these and these, this is a left bundle branch block. Okay, and if you do think that the patient is having this type of M pattern in V6, then this is again a case of the left bundle branch block. Okay, but what I always say that in left bundle branch block, you might not see this type of problems. I mean, in V6 you might not appreciate some M-like pattern. So this one is highly important. So you have to rely on this highly. Okay, so please you have to follow this picture if you're going to make a diagnosis of the LBBB. And if you're also getting some sort of pain, so this type of LBB is also equivalent to a cellular MI, as I've said it earlier. And what next? What are the causes of the LBBB, left bundle branch block? The number one reason why the patient might have LBBB, that is the ischemic heart disease. Okay, so having chest pain is very important. If the patient is having chest pain, you need to consider, might need consider thrombolysis issue to the patient. Okay, if you do think the patient is coming in within the window period. And of course the hypertension might be aortic stenosis or a different type of cardiomyopathy. And there are some rare causes like hyperkalemia, dioxin toxicity, or the idiopathic fibrosis. Okay, a patient might have left bundle branch block. Okay, that's very, very important. So they are saying that new LBBB is always pathologic and maybe sign of the myocardial infarction. This line is very, very important, very, very important. Now this line is no more restricted for the cardiologist. I think in every medicine specialist they must know that new LBB or the new onset left bundle branch block is equivalent to ST elevated MI. I mean, this is a part of the myocardial infarction, so you need to know this well. So diagnosing a myocardial infarction for the patient with the existing LBBB is difficult. Then the reason why they're saying, if you think the patient is having chest pain, so consider it a MI. Okay. So there are some criteria protocol, but we don't follow. Now the ECG, ST elevation, cause of the ST elevation. The number one thing that is very important in MRC part on ST elevation, and if you are going to consider any reason behind the ST elevation, of course, the MI, I mean ST elevated MI, I mean the acute coronary syndrome due to the ST elevation MI. The another thing that's important, that is the pericarditis. Okay, that's very, very important. Yeah, there are some normal variant, I mean the high takeoff. Okay, so don't be confused after finding this. So they might make you confused, or they might you might fall in danger after looking at the picture in MRC part 2. If the patient is not having any sort of chest pain, the patient is not having any other issue, not even any temperature, raised temperature, or any short of breath, or any other issue, or any peripheral stigma of the endocarditis or pericarditis, whatever it is, so then it might be a case of the high take off. So it's a normal variant, high take off, normal variant. Okay, why I'm saying this, recently I have seen a case in ICVD in Bangladesh. The patient was somehow mistakenly diagnosed with a case of the pericarditis, but after reaching in ICVD, the patient was diagnosed as a case of the normal variant, high takeoff. So also this is very common, and in MRC part 2 this is also common. So another thing, the patient might have a ST elevation, there is a left ventricular aneurysm. That's very, very important. So in left ventricular aneurysm, the patient might have some causes, might have some ST elevation as well. And another thing, that is the Prinzmetal's angina, coronary artery spasm. So regarding the Prinzmetal angina, as you know, it's very difficult to make a diagnosis of Prinzmetal angina. So what I have seen regarding the MRCP exam, that might not match with the practical knowledge, that might not match with your residual knowledge, or what you do know from your residual information, that might not match, but doesn't even matter. What I have seen in MRCP setting, that is they will consider the Prinzmetal angina if you do think the patient is having chest pain after the meal, after taking the meal, or at night time. Okay, so if the patient is having any chest pain after the meal or more at night, then always try to consider this sort of problem. Well, after excluding the GIT causes, esophageal causes. Okay, after excluding the esophageal causes, because in benign esophageal stricture there are also some features that match with the Prinzmetal's angina. So you have to be very careful, because if you're in Prinzmetal angina, the patient will be having coronary artery spasm, and in benign esophageal spasm or stricture, you know, there is also some esophageal spasm or benign esophageal spasm or stricture, what it's called. And the rare other causes, like in subarachnoid hemorrhage or part of the spectrum change, the hyperkalemia, there might be some ST elevation. So all these things together, they're very, very important. And what about the ST depression? ST depression, it does mean it might be secondary to any kind of abnormal Cure's complex, like any sort of bundle branch block or any sort of ventricular hypertrophy. Might be due to the ischemic causes. Okay, and also you have to consider the most important two, that is the hypokalemia. And if you do think that the patient is having ST depression that has a reverse tick look, you know the Nike sign, so that is the reverse tick sign. So if you do think that is a reverse tick sign, then you have to consider the digoxin toxicity. Okay, digoxin toxicity. So what I say, if you do think the patient was, or if you do think the patient is having a marker of potassium, I mean the potassium level is given, also the pulse rate, the patient is having low pulse, the rate is low, I mean the patient is having bradycardia, and ECG there is some ST depression. So All these things together, they make the diagnosis of the digoxin toxicity high likely. As you know, in digoxin will make the patient bradycardic. Digoxin in hypokalemia, digoxin toxicity is more. Okay, in hypokalemia, digoxin toxicity more, and even hypokalemia itself, it causes depression. So you have to know in this way if you are going to make a diagnosis over there in your exam. Another thing that is the syndrome X, not that much important in MRCP setting. Whatever the changes in hypothermia, well, in hypothermia there might be changes of the bradycardia. The patient might be having bradycardia, and most important thing what you need to know, that is the J wave. I mean, there might be some small harm at the end of the QRS complex. So J wave is very, very important. Okay, so follow the J wave, whether the patient is having J wave or not. Okay, J wave or Osborne wave, whatever it's called, you have to follow the J wave. And also the patient might be having some PR prolongation and also some QT prolongation, and might have some atrial or the ventricular arrhythmia. So in hypothermia, hypothermia is a very important talk in MRCP part 1 part 2 exam, not important in PACES. Hardly it will be seen in MRCP part 2 exam, mostly it will found in MRCP part 1 exam. So hypothermia is important for now, but not that much important in part 2. Again, I'm saying, if you're getting a case of hypothermia, then of course this is all about the ECG finding, they'll give you the ECG, and they will just jump into the question. So what is your cumulative diagnosis? This is the diagnosis of the hypothermia. Why I'm saying this, you have to focus on the heart rate. You have to see whether there is any sort of J wave followed by the QRS complex, and whether there is any sort of PR or QT prolongation, and you have to know about the rhythm pattern, whether this is a normal or any irregularity in between this. So this is how you have to finish the ECG. What are the clinical parameters, what are the pulses? Okay, this is very, very important. Now we're going to know details of the pulses. You know that in MRCP exam, pulse is very important talk, and you will be given so many questions regarding the pulses. Okay, so the first talk is the pulses paradoxes. These are all the abnormal pulses, not the normal pulse. Okay, so pulses paradoxes. What was that? You know that usually what it happens when we take a deep inspiration. You know, there is some systolic fall. Okay, there are some systolic fall, and that's almost up to 10 millimeter marker, and this is a normal finding. So there might be some greater than the normal 10 millimeter fall in systolic blood pressure during inspiration. Again, I'm saying, so up to 10 millimeter fall, that is a normal during the deep inspiration. That is a normal finding. But if you do think there is fall even more than 10 millimeter mercury during inspiration, there is something abnormal. And reason why, when the patient is having deep inspiration, the high chance of getting attack of the syncope. The patient might complain of faint, the patient might complain of dizzy-headedness, or even some absent pulse. So then you have to consider might be case of the pulses paradoxes. So when it will be seen, it might be seen in a case of lung cause, and another is the heart cause. What is the heart cause? If there is pericardial fluid in the pericardial cavity, so we'll call it the cardiac tamponade. And the another thing, that is the severe asthma. So in severe asthma and the cardiac tamponade, the patient might complain some pulses paradoxes. So how will be asked regarding this question? That is the faint issue, or any lightheadedness issue, or an absent pulse during deep inspiration, like this way. And you might be given some data regarding the ECG findings. What's that? The patient is having low voltage ECG criteria. Again, I'm saying low voltage ECG criteria. Well, in clinical practical life, if you are getting a case of low voltage ECG, then of course you are going to check the thyroid profile of the patient. Okay, that's fine. We also do that. But whenever it's all about the MRCP exam, no, you have in MRCP exam, if the patient is having a low voltage ECG, it does mean there might be some attack of the what's called, that is the pulses paradoxes, the cardiac tamponade. Okay, it's not due to the hypothyroidism. I mean, the most common causes sometimes might not appear even in MRCP exam. So severe asthma and the cardiac tamponade is very important if you are getting any findings regarding the pulses paradoxes. So, but the slow rising of the plateau, If you're getting a case of the slow rising pulse, then you have to know whether there is any kind of obstruction or any outflow problem over there in the aorta. Might be case of the AS, aortic stenosis, might be a case of the hyper obstructive cardiomyopathy in that way. So if you're getting a case of the slow rising pulse during the MRCP exam, you have to consider the aortic stenosis. Actually, in severe aortic stenosis, there is slow rising pulse, not in every aortic stenosis. I mean, in aortic sclerosis or even in mild aortic stenosis, the pulse might be absolutely normal. So what about the collapsing pulse? Yeah, so now come to the collapsing pulse. Actually collapsing pulse is a very common finding. Why I'm saying this? Because sometimes after the exercise, like you are playing cricket, you are playing football, or if you're swimming and now you're going to check the pulse, you'll see that yeah, you have developed some collapsing nature of the pulse. So it doesn't mean that you are having aortic regurgitation. So having collapsing pulse doesn't mean all the time you will be having some clinical significance. No, it's not always pathological. So it has some physiological causes as well, like in pregnancy, like in hyperdynamic circulation due to fever, due to exercise, due to thyrotoxicosis. Okay, even in severe anemia, there might be some hyperdynamic circulation leading the patient to have a collapsing nature of the pulse. That's the normal thing and common thing, even in exam. Yeah, the other thing you need to focus on, that is the aortic regurgitation. So if you think the patient is having high bounding collapsing pulse or collapsing nature, yeah, then of course you have to focus on the blood pressure. If you can see, this is also widening of the pulse pressure, so might be this is the case of the aortic regurgitation. Okay, another thing that's also important, there is a patent ductus arteriosus, but somehow that's not that much related in MRCP with MRCP part 1 exam. It will be important in MRCP part 2 exam. Again, it will be asked in the PACES exam, because suppose you have got a case of the aortic regurgitation and the teacher will be the examiner will ask you why you are saying the aortic regurgitation. Then of course from the starting point you will say that my patient is having a collapsing nature of the pulse. Then you will be asked, well, do you think that this collapsing pulse is due to aortic regurgitation, or will you consider any other issues? Then you have to focus on the anemia, then you have to focus on the pregnancy profile if the patient is a female, or then you have to focus whether the patient is a known athlete or not. Then you have to focus whether the patient is having any other murmur, like any machinery murmur, I mean present both in systolic and diastolic, most commonly hard on the back of the patient. So that is due to the patent ductus arteriosus. In this way, you need to make the diagnosis. Now, pulsus orderliness. Pulsus orderliness, again, a very common findings in heart failure. We call it the severe left ventricular failure. So in severe left ventricular failure, pulsus orderliness, that is very important. There is some alteration of the force of the arterial pulse. So it becomes very difficult to differentiate in between the pulsus orderliness and the Bispherians pulse. Reason why they are written together is it becomes very difficult. Why I'm saying this, let me give you the explanation. In Bispherians pulse, was that there is a double pulse, I mean the two systolic peaks. Okay, so there will be some two systolic peaks. Why the patient might have some Bispherians pulse? Might due to the mixed aortic valve disease. Mixed aortic, might be a patient with AS with AR, might be having Bispherians pulse. So it looks like almost the pulsus alternans. Okay, almost it looks like almost the pulsus alternans. So this is the case of the pulse Bispherians pulse, not the case of the pulsus alternans. So what would be the ECG finding in exam setting? Okay, in MRCP part 2 exam, you'll see the first QRS complex is like in that way, and the second QRS is again this way, not that much wider. Just ignore my widening. This is I'm not doing it intentionally. Somehow I'm not good with the mouse. So and the next bit would be again something like this. Another one would be another would be taller, and followed by the shorter, again a taller and shorter. So this is known as the regular alteration of the force of the arterial pulse. Okay, so this is the pulsus alternans, and Bispherians pulse is the double pulse. You will see some double click. Okay, then you will gap, again a double click, again a gap, again a double click. Okay, why? Might be having some mixed aortic valve disease, so you have to focus on these things as well. So okay, now what about the jerky pulse? That's again a very important talk, and my question I was asked regarding this about the jerky pulse. আচ্ছা ওই পেজে এসে কি হবে জানেন তো ভুলে গেলাম এই যে এটা হ্যাঁ শর্ট স্টপ ওকে এটা ডিলিট করবো কিভাবে ওটা তো আগের না এটা তো ইয়া থেকে লিখছি আমি জুম থেকেই হ্যাঁ ওকে সো হোয়াট অ্যাবাউট দ্য জার্কি পালস ওইটার ইয়া কি এটা না So what about the jerky pulse? Jerky pulse is another important finding in MRCP part 1 exam, even in part 2 exam. So how they will give you the idea? First of all, in jerky pulse, the patient should not be more than 30 years old. Shouldn't be more than 30 years old. So if you can see the patient is a young onset patient or the young patient, very young patient, the patient was playing football or playing cricket or even might be swimming. And now the patient got collapsed in and now on the emergency department they're saying the patient is having ECG changes like this. I mean all the waves, our waves are very tall, and the patient on pulse examination the patient is having jerky pulse. What is the diagnosis? Well, this is the case of the hypertrophic obstructive cardiomyopathy, ASOCM, the case of ASOCM. That is very common in emergency part of the exam, very common. Okay, so the patient might be having hypertrophic obstructive cardiomyopathy. ASOCM may be occasionally associated with the bispherians pulse. Yeah, that's very true. So if you do think the patient is having bispherians pulse, it doesn't mean that the patient is having mixed aortic valve disease. Rather, the patient might be having ASOCM, hyperobstructive cardiomyopathy, because there are also these type of problems. Now the heart sounds, as I've said, heart sounds will carry some significance through which you have to make the diagnosis, like in this way. If you do think the patient is having loud fast heart sound, it does mean the patient might be having mitral stenosis. If you do think the patient is having soft fast heart sound, or that's not that much louder, so might be having mitral regurgitation. Okay, mitral regurgitation. And you know that in MR, in mitral regurgitation, any kind of regurgitation murmur that should displace the apex beat. So whenever you are going to consider a mitral regurgitation murmur or MR or any AR, I mean regurgitation issue, always focus on the apex beat. What's the location, what's the position of the apex beat, whether this is displaced or not. Okay, so follow on this again, I'm saying. So now what about the AS2? AS2 is due to the closure of the aortic and pulmonary valves. So it would be soft in aortic stenosis, and splitting is very normal, and splitting during the inspiration is normal. So if you do appreciate a split and that's in the inspiration phase, that's a normal variant, that's a normal finding. Okay, so when you're going to see the split, they will ask you, the examiner will ask you, when you are going to see the split. If you do say, yeah, in inspiration I'm going to say, no, in inspiration the split is normal. In inspiration the split is normal. So in atrial septal defect, if you do think there is a gross split in inspiration, no, that's not a split, that's a normal finding. If you do think there is a split in expiration, so yeah, that is a positive finding. You have to say this. Now what about the AS3? I mean the third heart sound. This is caused by the diastole filling of the ventricle, and you will be asked what is the reason behind that. That is the heart failure, I mean the left ventricular failure, even in the DCM, dilated cardiomyopathy, or even in the constricted pericarditis. Okay, so the S4, I mean the fourth heart sound. Yeah, fourth heart sound is, it's always, you have to remember the three things. Was that the obstructive outflow issue in the left ventricle, like might be in aortic stenosis, might be in hyperobstructive cardiomyopathy, or even in hypertension. Okay, why? In long-standing cases of the hypertension, there might be some hypertrophic changes of the left ventricle, might cause some obstructive issues, and reason why there might be a fourth heart sound. Well, why the patient is having this kind of heart problem? Because the atrial contraction against a stiff ventricle. That's very important, and you will be asked regarding this. What's the origin? What's the issue? Why the patient is having atrial contraction against a stiff ventricle? The answer is very simple, and there's the atrial contraction against a stiff ventricle. In HOCM, a double apical impulse may be felt as a result of the palpable swell. This again a very important talk. Now, sides of the auscultation of the valve is your talk. Okay, it's your job to know about the site. It's a very common thing. You won't be asked regarding this thing. This is a normal writing. Now the heart sounds, the S2. Yeah, as I've said it. Just let me take this one. Okay. So now the heart sounds, like we have to know the heart sounds. Okay. So as you can see here, the AS2 is caused by the closure of the aortic valve, closely followed by that of the pulmonary valve. So what I have said earlier in my class today, that there will be closure of the aortic valve at first, and after that closure, there will be closure of the pulmonary component. Okay. So as you can see, there are some gap in between this closure, so it will make a physiological split, and that will be audible. That might be audible. You can appreciate this split in the inspiration, and that's absolutely normal. In expiration, you shouldn't hear about this kind of any kind of split. So you do, if you do consider any sort of split, or if you have appreciated any kind of split in expiration, so of course there might be some pathology behind this split. Now you have to know what are the pathologies regarding this split. Yeah, so it might be the patient might be having any reversal of the split, like the patient is having early closure of the pulmonary component and then aortic component is getting closed. There might be a possibility. If you do the thing in expiration phase, there is a split, and there is some prolongation, so we will call it the widely split. Okay, that means some wide split. Okay, so if you do think the first heart sound is very loud, now listen to me very carefully, my dear doctors, listen to me very carefully. If you do think the second heart sound is loud, if you do think the patient is having second heart sound that is very loud, then two type of the hypertension that might lead the patient to have a loud second heart sound. What's that? Might be systemic hypertension, might be pulmonary hypertension. So you have to know the both circulation. Okay, so if you do think the patient is having a loud second heart sound, then of course you need to focus on whether the patient is also having any other features of the loud P2, like whether the patient is having raised APP, whether the patient is having any left parasternal heave. Okay, so you have to focus on these things together as well. Okay, if you do think the patient is having these and this, might be a case of the pulmonary hypertension as well. No, you don't have appreciated something like that, so it might be a case of the second heart sound due to the loud A2, not the P2. So might be this is due to hypertension, due to hypertension, or any type of the hyperdynamic circulation that might lead the patient to have loud S2. I mean the second heart sound would be loud. What about the reversal of the split? If you have appreciated, or before going to the reversal of the split, let me talk about the wide split. If you do think the patient is having split and that is wider than the normal, so what are the pathologies when you will appreciate a wide split? Number one, if you do think the patient is taking a deep inspiration, you know that in inspiration there is a physiological split, there is a normal physiological split. So if the patient is having a deep inspiration, the split might be longer. Once again, if the patient is having right bundle branch block, then there will be a wide split. Why I'm saying this? Because in right bundle branch block, the left bundle branch is absolutely normal, so the aortic component from the left side will be closed earlier than the right side. Okay, so the right side will be closed later after the aortic component get closed. Okay, so there might be some possibility of wide split here. What about the reversal of the split? Okay, so there might be some reversal of the split in case of the left bundle branch block, even in case of the severe aortic stenosis. So severe aortic stenosis is another very potential cause for the reversal of the split. So if you do think that there is a case of the reversal of the split, that might be due to the severe aortic stenosis as well. And if you think the patient is also having some radiation to the carotid area, well, this is due to the aortic stenosis. If the patient is having chest pain, well, this is again angina due to the carotid aortic stenosis. If you think the patient is having narrow pulse pressure, well, again the patient is having this kind of split or reversal of the split due to the severe aortic stenosis. If you do think the patient is having the pulse which is very low volume, okay, and slow rising, again this is due to the severe aortic stenosis which has made the patient to have reversal of the split. So not only the LVB will be responsible for this reversal, again severe aortic stenosis would be a potential differentials. And if you do think the patient is having a fixed split, as I've said it, then that would be in the atrial septal defect. And now what I have said it, that there will be some fixed split both in the inspiration and the expiration phases, okay, both in the expression and the inspiration phases. And also another thing, that is the aortic stenosis, but as you know, in aortic stenosis, the first the second heart sound, that would be soft. There are some mnemonics, always I do say that don't follow and don't rely on the mnemonics too much, it will fall in danger, definitely, believe me. Now what about the causes of the loud S2? Okay, now what are the causes of the loud S2? As I've said it, there are some physiological causes, there are some pathological causes of the loud S2, like the hyperdynamic state. Any type of the hyperdynamic state. Might be pregnant, okay, might be patient is having severe anemia, or might be the patient you are auscultating, you're going to auscultate the heart just after the exercise, okay. So any type of hyperdynamic circulation, you might find some loud S2. What about the hypertension? Yes, hypertension is another reason why the patient will have loud A2, or even if the patient is having pulmonary hypertension, there will be some pulmonary or loud P2. Or atrial septal defect without the pulmonary hypertension, there might be some loud S2. And what are the causes of the soft S2? Of course, aortic stenosis. Cause of the fixed split, as I've said it, ASD. What are the causes of the widely split S2? As I've said it, the wide split. So follow the normal physiological issue at first, like the deep inspiration, or might be having some RBBB, right bundle mass block, or might be some pulmonary stenosis, even might be the case of severe MR, mitral regurgitation. This is a tough one, severe MR. What are the causes of the reversal of the split? I mean, the P2 is occurring before the A2 is getting closed. There is the LBBB, or the severe aortic stenosis, might be having the right ventricular pacing. That's again a very, very important talk. Again, the WPW type B causes the early P2, patent ductal arteriosus. Now you know that why the patient is having WPW type B, why the patient is having the early P2. As you know that in WPW type B, you have to follow the bright, BRIGST, bright. It does mean B and then the right. So it altogether we are calling the bright. It does mean if it is a B variety, WPWB, the patient is having right-sided pathway. So right-sided pathway, so the contraction or even the closure of the pulmonary control would come first. Okay. So that is why there is early P2. Okay, and the aortic component is lagging behind. Reason why there is some delay in between this P2 and A2, and there are some pathological reversal of the split. That is very important. So don't forget about the WPW type B. And again, another issue, that is the patent ductus arteriosus. Okay. Now what about the murmurs? Again, a very, very hot talk for MRCP part 1 exam. Don't forget anything regarding the murmurs. Each and everything from the murmur option you need to know, and you have to be very, very specific. You have to very, very clear regarding any diagnosis that is associated with the murmur issue. Like if you are appreciating any murmur and that is supposed to be an ejection systolic murmur, so regarding the MRCP exam, the first thing what you need to consider, that is the aortic stenosis. Okay, aortic stenosis. So if the patient is having ejection systolic murmur, again I'm saying, if the patient is having ejection systolic murmur and that is louder on the right side or just below the right clavicle, I mean the aortic area, and if you can see there are also some radiation to the carotid area, so it might be case of the aortic stenosis. Now patient is having ejection systolic murmur, but that is only confined in the aortic area, no radiation. So what's that? That is the aortic sclerosis, not the aortic stenosis. Okay, not all the time patient with aortic sclerosis will have the murmur, but might be a possibility. So also consider these one, aortic sclerosis and aortic stenosis. The difference between this is very hot topic for MRCP exam as well. Well, so another thing that might come up with the ejection systolic murmur, that is the pulmonary stenosis. That's again a very important thing. Okay, but the location will guide you whether this is a case of aortic stenosis or this is a case of pulmonary stenosis. So if you have considered or if you have appreciated any ejection systolic murmur, then the location is very important. Very important. In the case of HOCM, also there is case of ejection systolic murmur. In ASD, there is ejection systolic murmur. Don't forget about this. Don't forget about this. The patient will be having ejection systolic murmur in case of ASD. So it becomes very difficult to differentiate in between the ASD and sometimes the aortic stenosis, even sometimes with the pulmonary stenosis. Now, what to do? So the main thing you need to consider regarding making a diagnosis of ASD, you need to follow the split of the second heart sound. So if you do think there is a split during the expiration, even in the expiration, in both phases there is some fixed split. So this is the case of the ASD, and believe me, in case of ASD, somehow the split is very prominent, very audible. Somehow the ASD is very audible. If you have already heard about this, then I think that will be very clear to you. If you are not habituated with this kind of findings, then it might be very difficult for you for the first time. Okay, but eventually you will be accustomed with this kind of findings, so don't worry about that as well. So in failures, there is also some chances of having ejection systolic murmur, though you know that in TOF there is the patient is also having VSD, but that doesn't create the pansystolic murmur what the patient was supposed to have. Now the hollow systolic or the pansystolic murmur, well, if the patient is having a moderate to severe MR or even moderate to severe TR, the patient might have some pansystolic murmur, okay, or the hollow systolic murmur that will be having a blowing nature, and that is a high pitched. Okay, and in how will you differentiate in between this one and the VSD one? Actually, in VSD, the pansystolic murmur, the type of the pansystolic murmur, that is a harsh in character. Okay, that is a harsh in character, unlike the EMA, that is a blowing in character. So there are some changes in between this. Another thing, in VSD, particularly in VSD, the murmur is somehow audible in all the precordial area. Okay, in all the precordial area. Well, I know even that in MR it is somehow also audible in the all precordial area if the patient is very lean and thin. That's another thing, but particularly in the VSD, the murmur is somehow audible in the all precordial area and doesn't have the classical radiation to the left axilla, unlike the EMA. Well, so that's how we need to differentiate in between these. Now, what about the late systolic murmur? Okay, late systolic murmur, the first thing what you need to know in MRCP part 1 exam and part 2 exam, of course, that is the mitral valve prolapse. Okay, that is the mitral valve prolapse. Now, if you have seen the patient is already a hypertensive patient. Okay, the patient is having some pulse issue, asymmetrical pulse problem. Okay, that's another thing. The patient, and there in MRCP part 2 exam, a chest X-ray is given. And they are saying they have appreciated a late systolic murmur. So as they are giving the chest X-ray, it does mean it might be a case of coarctation of aorta. Might be a case of the coarctation of the aorta, whether you will get the sign 3 or not. I mean, a problem like this. So coarctation of the aorta is another potential diagnosis over there in MRCP part 2, not that much important in MRCP part 1 somehow. So mitral valve prolapse is very important. In mitral valve prolapse, you might see a late systolic click. Okay, what about the early diastolic murmur? I mean the EDM. In aortic regurgitation or even in the pulmonary regurgitation, the patient might have some diastolic, particularly the early diastolic murmur. And almost all the diastolic murmur, all the regurgitation murmur has some blowing character, as you know, in MR or in AR, all the PR. So what about the Graham-Steele murmur? This is due to the pulmonary regurgitation, not due to the aortic regurgitation. So Graham-Steele murmur, I mean the GSM, Graham-Steele murmur, is due to the pulmonary regurgitation, again high pitched and blowing in character. So in pulmonary regurgitation, there is also an early diastolic murmur. This is a Graham-Steele murmur due to the pulmonary regurgitation, not due to the aortic regurgitation. But now, What about any pathology? Do you know about any pathology regarding the aortic regurgitation? Yeah, that might cause another murmur, that is the Austin Flynn murmur. So you know that in early diastolic in aortic regurgitation there is high chance of developing early diastolic murmur. But if you do think the patient is having a mid late diastolic, not the early. Now it's mid to late, might be mid or to the end of the late. I mean to the late. I mean. So mid to late diastolic, so then that might be another chance of getting Austin Flynn murmur, and that is very important. That is very common in MRCP patients exam. Okay, so in aortic regurgitation, if you think the patient is having some rumbling in character, and now you are very confused, well, what I should say, as we know that if you have got a case of mid diastolic murmur and that has a rumbling nature, of course this is MS. Of course that is a case of the MS. But if you do think the patient has some collapse issue, I mean the collapse variety of the pulse, or if you do think the patient, the fast heart sound is in that much louder enough to comment on the MS or regarding MS, so then you have to consider whether the patient is having Austin Flynn murmur or not. That it might be seen in severe aortic regurgitation, again have some similarities like the mitral stenosis, like the rumbling in character. Okay, so you have to follow this one, and you know the rumbling, well, that is a typical presentation in MS. Now what about the continuous machinery murmur, mostly heard on the back interscapular area? That is the PDA, patent ductus arterius. We know that there is a machinery murmur, so that was a patent ductus arteriosus. Okay, now what about the jugular venous pressure? I think you can take a break, and after the break we can start with the JVP. Or it might, I think it will bring some tiredness in guys. So do you have any other questions so far regarding what we have discussed today? Do you have any other question or any other query you want to know? So do you have any questions or any other query, or we can take a break? Okay, so we're taking a break, short break, and after the break we will start with the jugular venous pressure. That is very important in MRC part 1 exam and even in part 2 exam. Okay, so we're taking a short break. After the break we'll start. Okay, so let us begin again, starting with the jugular venous pulse. Okay, and there is a good news for you guys that we're going to start another class with our past questions. I mean the previous or the recent questions. We are calling it the recalls, and also we are going to give you some idea that how you need to solve the past test. Okay, as you know, there are some difficult questions in past test. That is very difficult for you guys to cleanse the diagnosis if you're a very fresher candidate. Eventually it's easier even to solve the past test, even 100 questions in a day. One day it will come that you are solving 100 to 200 questions from the past test, and nothing is actually giving you a headache. Achha. So we're starting with the jugular venous pressure or jugular venous pulse. As you can see here, a non-pulsatile JVP is seen in supravenageal obstruction. So the first important talk is here. So if you can see the jugular venous pressure that is elevated but not pulsatile. Okay, we're calling it the fixed elevation of JVP. So if you can see, there is a fixed elevation with JVP, with facial plethora, with facial puffiness, with conjunctival congestion, with oral cavity or mucosal congestion, with their plus minus bilateral hand swelling. So there might be a case of the superior venecable obstruction. So be careful regarding this one. And if you're going to consider any superior venecable obstruction, lymphoma, Pankos tumor, or any other occlusion problem, blood clotting problem, like might be due to the nephrotic syndrome, might be due to the antiphospholipid antibody syndrome, you have to exclude all the things together. But what about the JVP is raised and this is pulsatile in nature? Then what you need to follow, you need to follow some of the waves to make your diagnosis. So now I will give you the idea that how you are going to make the diagnosis. Okay, so how we are going to do that? First of all, we are going to know about the waves in JVP, jugular venous pressure. The number one, that is A wave. So we will appreciate the A wave in atrial contraction. So A wave, it does mean the pressure in the jugular vein when there is atrial contraction. Okay, so A for atria, A for A wave. So in atrial contraction we'll get the A wave. So if you don't think the atria is producing enough contraction, so there won't be a potential A wave, or there won't be a A wave. So in case of, as you know, in case of atrial fibrillation, the atria cannot produce that much enough contraction. Reason why, in atrial fibrillation you're not supposed to get any A wave. So again I am saying what it happens in MRCP PACES exam, and this mistake is a very common mistake in MRCP PACES exam. Sometimes the jugular venous pressure is elevated and the patient is having atrial fibrillation, the pulse is irregular, and now the examiner will set a trap for you. They will ask you, doctor, you have said the jugular venous pressure is elevated, what type of wave is this? Do you think this is a A wave? So sometimes taking some leading questions might fall you in danger. So some of the candidates, they somehow they try to say, yeah, might be, yes sir, there might be possibility this is due to A wave. No, if you're saying the patient is having irregularities in the heartbeat, I mean the rhythm, so why you are saying the A wave in JVP? So you know, this is contradictory statement. So you have to be very clever regarding this one. So if you are saying the patient is having A wave, it does mean this is due to the atrial contraction. So of course, if the atria is giving more powerful contraction, like in high atrial pressure, like in case of tricuspid stenosis, if you do think the valve between the right atrium and right ventricle, I mean the tricuspid is stenosed enough, so that is why the atria of the right atrium is giving enough pressure to produce a potential contraction. So of course it will produce a wave. In case of pulmonary hypertension, in case of pulmonary stenosis and the reverse flow, so the atria will give powerful contraction. Reason why, there will be some large wave. But in atrial fibrillation, no, it will be absent. Number one. Another important thing, the canon wave. That is very, very important. Why I'm saying the canon wave? There will be some canon wave if there is atrial contraction against a closed tricuspid valve. So if you do think there is a closed tricuspid valve, so there might be a high chance to develop canon wave. So you can see here the canon waves that would be visible here in case of complete heart block, or the patient is having any sort of ventricular tachycardia, or if the patient is having ventricular ectopics, or the patient is on nodal rhythm, or the patient is on single chamber ventricular pacing. So might be the patient is also having the canon waves. So what it happens in exam cases. In exam cases, if you are appreciating any canon wave, then the patient should have complete heart block. Okay, not the ventricular tachycardia, not the ectopic, not the nodal rhythm, or not even the single ventricular pacing. I'm not saying that it's not possible in exam, but it's very, very rare. So canon wave is equal to complete heart block for you guys. Okay, must know. What about the C? As I've said it, the A for atrial contraction, so C for closure of the tricuspid valve. So if you do think that there is a closure of the tricuspid valve, so closure of the tricuspid valve will produce some of the pressure in the jugular vein, and that will cause a C wave. So normally it's not visible. Okay, now what about the V wave? V wave, it is due to the passive filling of the blood into the atrium against a closed tricuspid valve. Now let me give you the idea that how you will get the idea regarding the V wave. Now look at here, due to the passive filling of the ventricle into the atrium against a closed tricuspid valve, so there is a filling of the blood into the atrium. Well, you can see the atria that is getting blood,
The atria is getting blood from where? From the superior vena cava or from the inferior vena cava. So again, the valve is almost closed. I mean the tricuspid valve, that is closed. Now think about it. The tricuspid valve is closed. So what about the situation of the ventricle? That is why the ventricle that is already constricting. Okay, so the ventricle on constriction right now at this moment. So it does mean the V wave for ventricular constriction. That does mean the atria is dilated here. Reason why the atria is getting blood from the superior vena cava or the inferior vena cava, and as the tricuspid valve that is already closed, so there might be some of the pressure due to the backflow of the blood, due to the passive flowing blood into the right atrium. Okay, as the blood cannot pass into the right ventricle, reason why there might be some of the backflow, there might be some increment, or there might be some elevation of the jugular venous pressure, might lead the patient to have a V wave. So it would be more and more enough whether there is any kind of contribution from the right ventricle. So what's that? If right ventricle is also giving you the blood through the tricuspid valve, and when there is blood leaking through the tricuspid valve into the right atrium, we'll call it the tricuspid regurgitation. Reason why in TR we are expecting to have a V wave. So if you do think the patient is having a murmur, pansystolic murmur on the tricuspid area, okay, and now you're saying that this is A wave, no, it doesn't make sense. So there should be a V wave. So TR, V wave. Okay, always remember, during the ventricular contraction, the TR will be more pronounced. That is why there will be a giant V wave. So giant V wave does mean TR. It does mean the powerful ventricular contraction. That's making the patient to have a leak of the valve. I mean there is a tricuspid regurgitation murmur, and reason why the patient is having a giant V wave. What about the descents? There are two types of the descents, as I've said earlier. There is the X descent, the Y descent. So why I'm calling it the X descent? This is the fall in the atrial pressure during the ventricular systole. So when there is a ventricular systole, there is some sort of fall in the atria, we're calling it the X descent. Why we're calling it the Y descent? When there is a opening of the tricuspid valve, just at the beginning, when there is a opening of the tricuspid valve, so of course there will be some fall in the vein. The blood, as you know, that for the gravity purpose, the blood now will be into the right ventricle. So of course there will be some descent here. That is the Y descent. So two types of the descent: X descent, Y descent. X for the atria, Y for the ventricle. Okay, X for the atria, Y for the ventricle. So now I think it's very clear to you guys. Now what about the canon waves in jugular venous pressure? What I've said it, that in canon waves, if you do think the patient is having a regular canon waves, then there might be case of the ventricular tachycardia or the atrioventricular nodal re-entry tachycardia, I mean the AVNRT, or the VT, ventricular tachycardia. If the patient is having irregular canon waves, then of course this is a diagnosis of the complete heart block. So, and this is very common, as I've said it, in MRCP exam, the complete heart block with jugular venous pressure, I mean with canon wave, that is very common. So you have to know these things very clearly. Now the infective endocarditis, as I've said it, if you are going to solve the recalls of MRCP part 1, part 2, even in PACES exam, then I think infective endocarditis should be the top of the list, of the important list. Okay, so now infective endocarditis, there are some criteria. We all know that this is the MD criteria, I mean the modified Duke criteria. So infective endocarditis diagnosed, how we can make a diagnosis of the infective endocarditis? There are some rules. Well, what are the rules? Number one, if you do think the patient is having pathological criteria and those are positive, number one, or the patient is having 2 major criteria, or the patient is having 1 major and 3 minor criteria, or the patient is having 5 minor criteria. So we all call it in that way. What's that? Like 215, P215. Okay, so now remember this thing, P125, P215, P215, yeah, P215. Always remember this thing, P215. What is the P? P means pathological findings. If the patient is having pathological findings, okay, infective endocarditis. 2 does mean the patient is having 2 major criteria. 1 does mean 1 major with 3 minor or some minor criteria. So, okay, so 2, 1, now 5. What about the 5? 5 means the 5 minor criteria. So infective endocarditis, or making a case of the or knowing something regarding the modified Duke criteria, that is the P215. 5, P215. This is how you need to know this. Now what about the pathological criteria? Pathological criteria does mean that you are getting the evidence, direct evidence by the histology or from the microbiological result, okay, from the pathological material obtained at the autopsy or the cardiac valve. I mean, you are getting the histological evidence from the tissue, okay, like the valve tissue. From the valve tissue might be some embolic fragments or the intracardiac abscess content, okay. So there might be some pathological criteria. What about the measure criteria? Measure criteria does mean the patient might show the positive blood cultures. What's that? There will be some 2 positive blood cultures showing typical organism consistent with infective endocarditis. And what is the typical organisms? Typical organism means the patient might have some infection with Streptococcus viridans. That is very common. Streptococcus viridans, and the other thing, the Hasek group. What is that? We'll know about the Hasek group later on. So okay, now patient might show some persistent bacteremia from the 2 blood cultures taken, and of course that is 12 hours apart, or 3 or more positive blood cultures when the pathogen is less specific, such as Staphylococcus aureus and Staphylococcus epidermidis. So it does mean if you're suspecting something like the Staphylococcus aureus or the epidermidis, then you have to take more and more sample. If regarding the viridans, not too many samples is needed to make the diagnosis, but that's because this is a typical organism. So when you're dealing with some atypical organisms or not that much common organisms, though we know right now at this moment that Staphylococcus is a very common organism in IVF users. It's not any more uncommon or atypical organisms right now at this moment, or even Staphylococcus epidermidis, this one too. So positive serology from any Coxiella or Bartonella or Chlamydia, or positive molecular assays for the specific gene target. So these are the positive blood cultures, okay. So these are the positive blood cultures. So now you can see here that the first one, 2 positive blood culture, okay, and again 2 with viridans or Hasek. Now again some persistent bacteremia, again with 2 blood cultures taken. Even better if you're taking the 3 samples with the atypical or rare or the uncommon organisms. And positive serology again with Coxiella, Bartonella or Chlamydia, and positive molecular assays for the specific gene target. These the last 2, that's not that much important for MRCP exam. Now what about the evidence of the endocardial involvement? Yeah, you have the patient should show some endocardial involvement. As you know that in infective endocarditis there should be some endocardial involvement or evidence of the endocardial involvement. So how you will rule it out? By imaging test, by doing the echocardiogram. So if you do the echocardiogram, in echocardiogram you will see some changes like the O change, that is we call the oscillating structures, like the A change we call it the abscess formation, like might be some R change, we call it the valvular regurgitation, and that should be a regurgitant murmur, like the patient is already having an existing murmur. No, existing, if the patient is having an existing murmur and that was an other murmur apart from this regurgitation, so you might include this one. And if you can see now the murmur, the character of the murmur has changed and it has turned into a regurgitation murmur. Of course this will bring some huge pathological significance, okay. And the other thing, that is what we are saying, the D for dehiscence. So what we call it in echocardiogram, we see the road changes, okay. In echocardiogram we call it the road changes, so we call it the endocardial road changes. So R means, again I'm saying the road is a mnemonic. So here R means regurgitation, O means oscillating structures or oscillating movements of the valves, A means there might be some abscess, new abscess, and the last for the D, there is the dehiscence of the prosthetic valve if the patient has any valve transplant history, okay. If the patient is having any valve transplant history. If the patient doesn't give you any valve transplant history, so then dehiscence of the posterior, no, you shouldn't think about it, okay. So say with me, just say with me from your side so that you can get it from in your brain, okay. So we will call it, what we will call it, we'll call it the road changes in echocardiogram, okay. The road changes in echocardiogram. Okay, thank you. Okay, there are some queries. We'll try to solve this query. Okay. So in echocardiogram, again, I'm saying if you do think that the patient is having some changes, that is the root changes, so you have to consider the infective endocarditis. Okay. Now, what are the minor criteria? Okay. So minor criteria does mean the patient might have some predisposing heart condition or IV drug abuse. So for MRCP part 1 exam, I always say somehow it will be there in your exam that the patient is a IV drug abuser. So it will make you more comfortable to get you or to cleanse the diagnosis. Yeah, this is the case of the infective endocarditis. Somehow this is a happy thing for us. And the second one, that is the microbiological evidence that doesn't meet with the major criteria. So from the microbiological evidence, if you do think that this not matching with the major criteria, so once again this is a minor criteria. Yeah, there might be some persistent fever, okay, fever more than 38 degrees centigrade, and there might be some vascular phenomena, as you all know, like the major emboli or the splenomegaly. Splenomegaly is very important in case of infective endocarditis. There might be some clubbing in the hands, some splinter hemorrhages, generations, petechiae or purpura, or sometimes the Roth spurs due to the immunological phenomena like the GN, Osler and Roth spurs. Now remember, I was asked from this chapter, I mean from this section in MRCP part 1, that which one is the immunological phenomena in case of infective endocarditis, and I totally forgot that which one is the immunological phenomena. I mean, is Roth spot or the Osler or the glomerulonephritis is the immunological phenomena. Okay, so I was suffering with some confusions over there in the exam. Anyways, so now what I do say that you have to know in this way. We'll call it the ROGI or ROGI, whatever you say, ROGI, ROGI or ROGI, so that you can remember thing every time. Okay, so ROGI or ROGI, whatever you say, ROGI or ROGI, just remember the ROGI. In Bangladesh we know the ROGI means patient. Okay, so ROGI, ROGI, R means Roth, O means Osler's, G means glomerulonephritis due to the immunological phenomena. So I, okay, so ROGI. So never forget this ROGI, never ever forget this ROGI, because it will make you suffer in the exam. Okay, so remember this thing. Now infective endocarditis. So there are some risk factors they are discussing regarding the infective endocarditis. The following types of the patients are affected, particularly previously normal valves, 50%, typically acute presentation. They will come up with the acute presentation. If the patient is having a rheumatic valve disease, a pre-existing valve issue, so 30% of cases. Prosthetic valve, again a very important thing, and congenital heart defects. The patient might have some congenital heart defect, and IV drug abusers, typically causing the tricuspid lesion. Somehow this one is very important regarding the MRCP part 1 exam. Somehow this is very important. So what are the causes? As we have discussed just when we started talking regarding this infective endocarditis, there are some typical and atypical organisms. So most common typical organism, that is the viridans. So this is almost near about the 50% of the cases where you will find the Streptococcus viridans being positive as a pathological microorganism. And the other things was that there is the Staphylococcus epidermidis. So Staphylococcus epidermidis, that will be encountered in case of prosthetic valves. They are saying that especially in prosthetic valves, for you guys, for the candidates, if you can see this is there is a history of the valve transplant, a patient is having a prosthetic valve. So think about the epidermidis at first. Okay, so epidermidis, it does mean the patient might be having prosthetic issue, prosthetic. So PAP, prosthetic. Okay, P for epi and P for again prosthetic valve. What about the Staphylococcus aureus? Usually Staphylococcus aureus will be presented in the IV drug abuser. So if you can see the patient is a IV drug abuser, if you do think the patient is an IV drug abuser, then the patient should be a case of the Staphylococcus aureus. Okay, so Staphylococcus aureus should be the pathological agent which has caused this type of infective endocarditis. So remember this one. Streptococcus bovis is somehow related with the bowel. So B for bovis, B for bowel. I mean, what is that? Bowel cancer. I mean the colorectal cancer. So B for bovis, B for bowel. For Streptococcus mitis, Streptococcus mitis was that there is following a dental work. I say M for mitis, M for mouth workup. What's that? I mean any dental workup, anything. Okay. So M for mitis, M for mouth. I mean any workup in the mouth cavity. Okay. So mitis, mouth. I mean dental work or any other thing. What about the non-infective causes? Yeah, then suppose the patient is having every features of the road. there are some regurgitation murmur, there's some oscillating movement, there's some descents, and everything. But from whenever you are going for the cultures, is absolutely normal. It does mean the aseptic involvement, right? So what's that? That might be due to the Liebman-Sack endocarditis. As you know, in Liebman-Sack's endocarditis, particularly seen in the SLE, systemic lupus erythematosus, the patient might develop some non-infective causes of the endocarditis. So as we are discussing the infective endocarditis, sometimes we have to discuss once again the non-infective endocarditis in a different entity as well. Okay. So malignancy sometimes come up with the features of the endocarditis, like the merantic endocarditis, as you can see here, but not that much important for the MRCP part on exam as well. Now, what are the causes? Historically, you can see here the Streptococcus viridans was the most common cause of the infective endocarditis. So this will be asked each and every time. What is the most common organisms? But remember, there are some fallacy. What's that? Now listen to me very carefully. This is no longer the case except the developing countries. So in developing countries, you can see the Streptococcus viridans is the most commonest organism that is causing the infective endocarditis. Now they're saying the Staphylococcus aureus is now the most common cause of infection. As in a start, I was saying regarding this. Nowadays there are some fallacies. Now as you can see, the Staphylococcus aureus is now the most common cause of infective endocarditis. So if you are asked in this way, there is the most common organism, and if you can appreciate the name of the Staphylococcus aureus there, you have to pick that one. And particularly for us in that way in developing countries, so of course viridans, you will have to go for viridans. So Staphylococcus aureus is also particularly common in acute presentation and in IV drug abusers. So again, I'm saying if you can see or if you can appreciate, this is a very or hyperacute presentation or a presentation by the IV drug abusers, again you have to jump onto the Staphylococcus aureus. The other things are the coagulase negative Staphylococcus, such as the Staphylococcus epidermidis, that is commonly colonized with the indwelling lines. So as I've said it, the Staphylococcus epidermidis in previous time, the patient might have some history of the prosthetic valve implantation. So, and again, now I'm saying I might be having some indwelling lines. So you know, there are some association with the epidermidis with skin. So if you are making some connection the blood with the or the body cavity or the your body inner structure with the outer structure, so then high chance of having this type of endocarditis attack with these type of organisms. So in patients who are following the prosthetic valve surgery, as we can see here, especially the result of the perioperative contamination. So this is very important. So if you have appreciated a perioperative contamination or perioperative history, then you have to consider this one. And after 2 months, the spectrum of the organisms which cause endocarditis return to normal. Staphylococcus aureus is the most common cause. Okay, Streptococcus viridans, again I'm saying, still accounts for around 20% of the cases. Technically, Streptococcus viridans is a pseudotaxonomic term referring to the viridans streptococci. Okay, they are giving you some idea regarding here. You have to just know the names, and of course you have to know the names of the organisms that might cause infective endocarditis due to the dental workup or any workup in the mouth cavity. Okay, so that is the issue. I mean the mouth and in particular dental plaque. So endocarditis is caused by these organisms linked with the poor dental hygiene or following a dental procedure. So these are the organisms again. So Streptococcus bovis, I have said it, B for bovis and B for bowel. So if you can see there is a bowel involvement, so you have to know this one. And this question is very common in MRCP part on exam. Okay, so they will give you that data. The patient is having a bowel cancer. Now what is the organism that has caused this patient to why the patient has developed infective endocarditis? What is the organism behind this? So you have to pick the Streptococcus bovis. Now the non-infective cause, as we have said it, the systemic lupus erythematosus, very important thing, malignancy, meningitis, endocarditis. And reason why, if you have got a case of SLE in case of in PACES, then the examiner will ask you, doctor, or doctor, have you auscultated the precordium? So you will say, yeah, I have, yes sir, I have auscultated the precordium. Or somehow suppose you didn't examine the precordium, and now it's a high time that you realize, oh my god, what I have done, I didn't examine the precordium at all. Now you're saying, no sir, I'm very sorry, I had to examine the precordium. Then they will ask you what will be your findings and what you're going to see over there in the precordium. Okay, so until you were saying regarding this one that it might be some regurgitation murmur, they will keep asking you what next. Suppose you have said yes, there might be some valvular involvement or leaking valve issue like the regurgitation. Then they will ask you why this is a leaking valve, and why the patient is showing up pansystolic mama here. What's the reason behind this? Then you have to say, yeah, there might be this infective, non-infective cause, like the Liebman-Sack endocarditis, why the patient is having this. Like in malignancy, you will be also asked, why do you need to examine the precordium, and do you want to check the bedside urine test? Yeah, in any type of the malignancy, we need to check the precordium due to the chance of take endocarditis, and you have to check the bedside urine examination or heat coagulation test just to see whether this malignancy is associated with the nephrotic syndrome or not. We all know we have to go in this way. So as you know that this is a post-grad exam, so you have to know in this way. Okay, so culture negative causes. What are the culture negative causes? Like the patient has taken some antibiotics, but that the patient isn't compliant that much, but somehow has taken some doses of the antibiotics, because prior antibiotic therapy cause culture might cause the culture negative. And if we are coming up with some atypical organisms or the previously known, commonly known, the HA group. What's that? The Coxiella burnetii, Bartonella, or the Brucella, and the HA group, that is the H for Haemophilus, A for the Actinobacillus, C for Cardiobacterium, and E. cannella and Shigella. So following prosthetic valve surgery, following valve surgery, again I am saying, following any kind of skin involvement, following the prosthetic valve involved in any skin issue, the patient might develop endocarditis due to the Staphylococcus epidermidis, and this is the commonest organisms in the first 2 months. Again I am saying, for the first 2 months. Later after, it's not the usual organisms. First 2 months is usually the result of the perioperative contamination. So you will have to consider the epidermidis. If you can see this, there is a perioperative issue. After the 2 months, what will be the most common organism? Of course, the organism that is also residing in the skin, but another organism. What is that? There is the Staphylococcus aureus. Okay, so first 2 months go for epidermidis. After the 2 months, go for the Staphylococcus aureus. Okay, so you have to think in that way. Now, infective endocarditis, what about the prognosis and what about the management? There are some poor prognostic factors. Why we are that much concerned with endocarditis with Staphylococcus aureus? Because it carries bad prognosis. Okay, so Staphylococcus aureus infection, it will carry some poor prognostic issues. If the patient is having a prosthetic valve issue, and now he is coming up with the valve leak, okay, or valve leaking issue, you know, he is or she is in danger. So prosthetic valve, especially early occurring during surgery, and culture negative endocarditis. Yeah, so you don't know that why the patient is having endocarditic attack. So it will of course bring some poor prognostic issue. And if you can see, there are some complement consumption issue. So the level of the complement that will be lower in the blood. So mortality according to the organisms, due to Staphylococcus 30%, bowel organisms 15%, Streptococcus 5%. Not that much important for exam. So what you need to do, at first you need to initiate some antibiotic therapy to save the patient. So we are calling it the IBT, I mean the initial blind therapy. So if the patient doesn't have any prosthetic valve issue, all the patient have is native valve, then you can consider simply the amoxicillin. Also you can consider gentamicin here. But what about the amoxicillin? As you know that in NHS or in UK, maximum patients are penicillin allergic. In that case, you need to check the allergy level of the patient, whether the patient is sensitive with penicillin or not. If you found the patient is allergic with penicillin, then what do you need to consider? That you need to consider the vancomycin with again gentamicin. And if the patient is having prosthetic valve, so no chance, you need to consider gentamicin and vancomycin along with the rifampicin. Okay, rifampicin is a reserve drug, we all know. Okay, so native valve endocarditis caused by the Staphylococci. You know that the organism is Staphylococci. So if it is Staphylococcus aureus, of course you need to give any antibiotic that is covering the Staphylococcus, like in flucloxacillin. If the patient is somehow allergic with flucloxacillin, then simply vancomycin and rifampicin. What about the prosthetic valve endocarditis that's causing the Staphylococcus? Again, I'll give flucloxacillin with rifampicin. So you can see if there is any prosthetic issue, rifampicin is a choice. Huh? Okay, so and if penicillin allergic, then we'll give vancomycin, rifampicin, and again the gentamicin. What about the endocarditis caused by the fully sensitive streptococci, like in case of the viridans? Here we'll give the benzyl penicillin. If the patient is found to be penicillin allergic, then vancomycin with the low dose gentamicin. I know this is very tough to know, but you will be asked regarding this, even in PACES, even in part 1, even in part 2, everywhere. Like I was asked regarding this chart, And if I'm not wrong, for the 2 minutes, for 2 minutes, my examiner kept asking me all the questions from this box. If this is positive, if this the patient is having this issue, so what will be the next? If the patient is having this issue, so what will be the next? Well, I'll trying to give the my level-based answer, and I think I did cover almost all the things written here, and that is why maybe I got some good numbers over there. But again, I'm saying on that topic, I lost some numbers because I really forgot some of the very key points and very notable point over there in the exam and paces. So indications for the surgery. Yeah, even I was asked regarding this, that when you will go for surgery, okay? Like if you have given the antibiotics, but no, that's not working. Or if you do think the patient is having severe valvular incompetence, I mean, there is a regurgitation and there is very severe, so you have to go for surgery. If you do think the patient is having first degree heart block, that is evidenced by the long PR in the ECG, so again I'm saying it does mean the patient is having aortic root involvement with the abscess, so you have to go for surgery for the drainage. Again, if you think the patient is having a fungal issue due to the evidence by the culture, so again you have to go for surgery. And if you think the patient after giving the standard medical treatment, no, the patient isn't showing any kind of response, rather the patient is developing heart failure, so again you have to go for surgery. Another thing, if the patient gives you recurrent emboli attack, remember, forget about the endocarditis. You all know in any kind of valvular heart disease, we consider some sort of anticoagulation, isn't it? Like in mitral valvular heart disease, sometimes like in case of severe MS, or in case of mitral stenosis, sometimes you're considering the anticoagulation. But even after considering the anticoagulation, if the patient is having recurrent attack of thromboembolic manifestation, it's again an indication to go for surgery. So that is a very important point to add on. Okay, now infective endocarditis, is there any particular prophylaxis? Yeah, sometimes there are some prophylaxis the patient should have, sometimes there are some prophylaxis the patient shouldn't have, but unfortunately in previous time the patient used to get some of the prophylaxis, so you might fall in danger. Like in your residual knowledge, you know that due to this workup or due to this thing, the patient should have prophylaxis. But right now in MRCP exam, when we are going for the MRCP part 1 exam, now they are saying, or the new data or the new guideline, they are saying no need to go for prophylaxis. Now we need to be very careful regarding this topic. Okay, if you can find, yeah, this is almost contradictory with your residual knowledge. Like in case of NICE, what NICE recommends us that the patient shouldn't take any kind of prophylaxis if the patient is having any mouth workup, like any dental procedure, if the patient is having upper or lower GI tract procedure. As you know that bovis can be the culprit organism here, mitis can be the culprit organism here. Again they are saying no need. Usually these patients used to get antibiotic in the previous time, but right now it's not recommended. So this is the learning from here. If you can see the patient is having genitourinary tract issue, like urological, the gynecological or obstetric procedures, or the childbirth, upper lower respiratory tract, that includes the ear, nose or throat procedures or bronchoscopy. So you can see that no, there is no need to take the prophylactic medication here. So the guidelines do, however, suggest that any episode of the infection in people at risk of infective endocarditis should be investigated, treated promptly to reduce the risk of the endocarditis development. So they are saying if you think the patient is at high risk to develop this, then go for investigation whether the patient is having this type of attack or not. Is getting this type of attack, you can go for a medication. So if you do think the person is at risk of infective endocarditis receiving antimicrobial therapy because they are undergoing a gastrointestinal genitourinary procedure or at the site the suspected infection, they should be given an antibiotic that covers organism that cause infective endocarditis. Yeah, that's the learning from here. So now another important talk, and that is very important talk, that is the aortic valvular heart disease. So now think about it, that what are the presentation of the valvular heart disease. Like if you have got a case of the aortic stenosis, particularly aortic stenosis, the patient would be elderly one. So in aortic stenosis, what's the reason behind this? In maximum cases, there will be some degenerative changes. As we know, degenerative changes in mitral valve is less common, and in aortic valve is more common. So if you do think the patient has developed now some narrowing of the valve, we are calling it the aortic stenosis. So there might be some low perfusion to the heart wall during the systole or during the diastole. So the patient will have some anginal issue, I mean a chest pain. Okay, so there might be some angina due to the aortic stenosis. Also, the patient might develop short of breath. Even there are some low perfusion in the brain, reason why the patient might develop some syncope attack as well. So if you do think these 3-1, like the chest pain, like the short of breath, I mean the dyspnea with syncope, you have to think regarding the aortic stenosis as well. So how it will be evident? It will be evident by having a narrow pulse pressure, as we have discussed earlier, by slow rising pulse. Once again, we have discussed earlier, might be some ejection systolic murmur in aortic stenosis. We have discussed again with some carotid radiation. And in aortic stenosis, we all know the S2 would be soft, I mean not louder, unlike the mitral stenosis where the first heart sound used to be louder. And here S4, you might expect a heart sound, another extra heart sound, we are calling it the S4. S3 also will be audible when if the patient is on gallop or if the patient is on heart failure. The patient, of course, for the exam MRCP purpose only, I am saying, if the patient is having any systolic issue, so the patient should have a systolic thrill. Okay, so there will be a systolic thrill that is palpable on the aortic area. And duration of the murmur, that's also important. Sometimes duration of the murmur, not the intensity, I must say. Duration of the murmur sometimes carries significance, not the intensity. And left ventricular hypertrophy or failure, yeah, eventually there will be some hypertrophied left ventricle. And causes of the aortic stenosis, why the patient is having aortic stenosis in an elderly patient, what will suspect? Yeah, might be degenerative changes. But if you do think the patient is young enough, then you have to think about the BAV. What is that? There is the bicuspid aortic valve. There are some other issues like rarely rheumatoid heart disease, rarely ASOCM will come up with the features of the aortic stenosis again. Okay, Williams syndrome, there is a supravalvular aortic stenosis, rarely it will be encountered in MRCP part 1 exam. So how will you manage? If you do think the patient is asymptomatic, somehow you have appreciated a murmur, but the patient is not having chest pain, the patient is not having short of breath, the patient doesn't have any syncope. Syncope is the most important thing in aortic stenosis, I must say. So then you can observe the patient, okay, and you can annually check the patient. You can auscultate the precordium, you can go for echo. I mean, you have to review the patient annually. If you think the patient is having symptomatic attack, then of course you need to go for valve replacement, particularly syncope attack, then you have to go for the valve replacement surgery. Again, if you think the patient is asymptomatic somehow, but on echo the valvular gradient is very high, more than 40, but here it's written that more than 50. Okay, both are correct. So if you do think the valvular gradient is more than 50 millimeter mercury and the features such as left ventricular dysfunction, then consider surgery. So again I'm saying three things: symptomatic, valve gradient, heart failure, aortic stenosis with heart failure, surgery. Aortic stenosis with valve gradient more than 50, go for surgery. Or the patient is highly symptomatic, again go for surgery. Balloon valvuloplasty is limited to the patients with critical aortic stenosis who are not actually fit for the valve replacement surgery. In those cases, you can consider the balloon valvuloplasty. Another surgery we know, we are calling it the TAVI, transaortic valve aortic valve implant, you know. So transcatheter aortic valve implant, TAVI. TAVI is very common nowadays, and even in Bangladesh, we have some TAVI center. So you have to know the TAVI. Why I'm saying TAVI? TAVI was a recent case in MRCP cases, and diet 2 and diet 3 in 2023. Yeah. And angiodysplasia was that again a 5-star talk in MRCP part 1 exam, not very common in MRCP part 2, not even common in MRCP cases, but for totally a part 1 topic, that is the angiodysplasia. So how question will be coming from angiodysplasia? Let me give you some idea. Why you are calling it angiodysplasia? It does mean angiodysplasia, I mean the vessel dysplasia, some vessel deformity, I must say. Why it's happening? In the GIT tract. So in the gastrointestinal tract, there might be some vascular deformity. Reason why the patient might have some recurrent attack of the bleeding. Reason why the patient might develop some ID, iron deficiency anemia. So first of all, vascular dysplasia in GIT, bleeding with iron deficiency anemia. So why we are considering it with the aortic stenosis, or we are discussing it here in cardiology, because it has some association, is thought to be It's just a thought. There is some gross association with some aortic stenosis. The patient might also have aortic stenosis, though this is actually debated. Angiodysplasia is generally seen in elderly patients. So if you can consider things like this, I mean the patient is having iron deficiency anemia with aortic stenosis. Okay, so I must say this one, aortic stenosis. Again I'm saying aortic stenosis. So for aortic stenosis, you can see here as aortic stenosis, so you can see here the AS, okay, along with the IDA. So AS with IDA, so what's that? ASIDA. Okay, so you used to call it the ASIDA. Okay, so aortic stenosis with iron deficiency anemia, if you are having some similarities in between this, so you have to consider the angiodysplasia. So how will you consider? You have to go for the colonoscopical view. You have to check, or you can consider the mesenteric angiography only when the patient is bleeding acutely. So if you can see the patient is having acute bleeding, go for mesenteric angiography. Okay, MSA. If you go for the mesenteric angiography. And how will you manage the case? You can consider the endoscopic cauterization or argon plasma coagulation. You can simply manage the bleeding by giving transmitting acid, or you can give estrogen, may also be used. Okay, what about the AR? In AR, we're suspecting a murmur like the early diastolic murmur, and as I've said it, in AR the murmur should be in collapsing in nature. There might be wide pulse pressure in a severe aortic regurgitation, not a simple aortic regurgitation with hypertension, and might be some mid systolic murmur in early diastolic phase, and that might even lead to Austin Flynn murmur in severe AR due to the partial closure of the aortic mitral valve caused by the regurgitation stream. So then it will be some mid diastolic to late diastolic murmur as well. So be careful regarding this thing as well. So what are the causes of the AR? What are the number one thing that you need to know regarding the AR, not the AS? AS, calcified aortic valve, might be degenerative calcification. Number one. AR, the number one, endocarditis. The number one is endocarditis. Regarding the exam purpose, if you are considering the clinical issue, then rheumatoid valvular heart disease. Another one that is also again very important, that is the bicuspid aortic valve, that might come up with the aortic regurgitation. Again I am saying, be very careful. What I have seen in the recent times, if you are having any aortic valve issue, might be aortic stenosis, particularly aortic regurgitation, please exclude the Marfan syndrome at first. Marfan syndrome as well. So try to check for other Marfanoid habitus, whether the patient is having these or not. Okay, particularly the vision, the lens dislocation issue. Okay, but be very careful. So another thing, that is RASLE and bicuspid aortic valve, what we have discussed. Again, consider the Turner syndrome, because in Turner syndrome there is bicuspid aortic valve, that is very common. Okay. And what are the causes? Due to the aortic root disease, you can see here the aortic dissection, the spondylorthopathy, hypertension, syphilis, the Marfan, as I've said it, the Marfan, exclude the Marfan. Oh, another thing that's very important, I must say, that is the psoriatic arthritis and the ankylosing spondylitis. So if you do think the patient is having a low back pain or the nail changes, then psoriatic arthropathy, or focus on the ankylosing spondylitis, because ankylosing spondylitis is very common with aortic regurgitation, and again very important with complete heart block. So if you do think the patient is having early diastolic murmur, patient is a past history of a surgery, precordial surgery, particularly the pacemaker implantation, and now the patient is coming up with some short of breath or racing pacing of the heart with some chest pain, with some regurgitation murmur. Okay, so then you have to consider ankylosing spondylitis again. I mean the seronegative arthropathy again, and that's very common. Again, you have to consider the syphilis, also very important. In tertiary syphilis, the patient might develop the AR. All these are very important. You might think, see how many patients with syphilis you have seen developing the AR. No, that doesn't make sense. That doesn't. Please don't ask this type of question. That's not the deal. As I've said it, everything is common if you can make the diagnosis. Everything is rare if you cannot make the diagnosis. Okay, so you have to make a diagnosis here. So now, as I've said it, you have to focus, or you have to exclude the Marfanoid habitus, reason why we are going to discuss about it. So as you know that in Marfanoid habitus there will be some features like the arm
arm span, if we are getting the arm span to the height of the patient, that will be more, and that will be more than 1.05, the patient will be having high ars pallis, might be some arachnodactyly, pectus excavatum, pes plana, scoliosis, there is more than 20 degrees. In heart, there might be some murmurs, and of course there is the dilation of the aortic sinus. Reason why the patient might develop aortic dissection or even aortic regurgitation, they might be develop MBP, mitral valve prolapse, and 70% of the cases the patient might develop mitral valve prolapse. And in lungs, there is some repeated pneumothorax. In eyes, there is lens dislocation, and there is the upward lens dislocation, unlike the homocystinuria. Okay, unlike the homocystinuria, the patient also might have some blue sclera, and myopia. And there might be some dural ectasia, ballooning of the dural sac at the lumbosacral level. Now let me give you the idea that from how they are giving the questions from the Marfanoid habitus. Okay, what I have seen recently, the recent question from the Marfanoid habitus was the pneumothorax. The patient is having recurrent attack of the pneumothorax. Well, if you do think the patient is having a recurrent attack of the pneumothorax and the patient is not that much elderly, so if the patient is not that much elderly, so it doesn't mean due to the COPD, the number one cause we all know. If you think the patient is young enough and now showing repeated attack of the pneumothorax, then the number one thing what you need to consider, Marfan syndrome. The second thing what you need to consider, that is the HIV. I mean, you all know that in pneumocystis jirovecii, the patient will have high chance to develop the pneumothorax, and it will be repeated. If the patient doesn't get treatment with the cotrimoxazole, then repeated attack of the pneumothorax there will be in pneumocystis jirovecii as well. So Marfanoid habitus with the pneumocystis jirovecii, that is very common in exam as well. And of course, last but not the least, COPD. Yeah, the most common thing or the commonest thing across the globe. Of course, you need to focus on this thing as well. So from the Marfanoid issue, question might come up from the lung sector. What are the eye sector? Vision problem, the lens dislocation. From the aortic section, due to the aortic root dilation, we usually know it might lead the patient to have a dissection. Once again, the aortic regurgitation along or not along with mitral valve prolapse. The other thing, that those are not that much important for the exam purpose. Okay. Now, osteogenesis imperfecta. Osteogenesis imperfecta is a 3-star topic from this cardiology talk. It's important more from the rheumatological issues. So you just go through this. Ehlers-Danlos syndrome. Again, Ehlers-Danlos syndrome is another important talk that might come up with features of the aortic regurgitation, and again with mitral valve prolapse. So how will you differentiate in between this? Now let me give you some idea that why Ehlers-Danlos syndrome is very important. Ehlers-Danlos syndrome patient has some joint hypermobility issue. You all know there are some recurrent joint dislocation. So that's very important, and the patient will develop some easy bruising. Okay, easy bruising. So if you do think the patient is having easy bruising issue, even without steroid, even without weight gain, even without any history of the Cushing, even without any platelet disorder, even with a liver disorder, then please consider Ehlers-Danlos syndrome and please check the precordial findings. Okay, I'm giving you the idea. Another thing that is very important in MRCP part 2, not important part 1, because you will be given an image of the retinal, I mean you will be given a retinal photograph, and there you can see the injured retinal streaks. In MRCP part 2, you need to see that how injured retinal streaks it looks like. Okay, it's not needed now. So what about the mitral stenosis? Yeah, that's of course mitral. If you are getting a case of the mitral stenosis, the number one the cause behind this mitral stenosis would be of course the rheumatoid valvular heart disease issue. So in MS, the patient will generally complain about racing pacing of the heart. Okay, might be some irregularities with the regular heartbeat. So there might be some irregularities of the heartbeat. So racing pacing of the heart with short of breath, with features of the left ventricular failure, the patient also might develop, again with some features of the pulmonary hypertension. As you know, MS is very common with pulmonary hypertension. So anyway, the features would be some mid-diastolic murmur. Of course, it is the left heart murmur, so it will be based hard on the expiration. And there will be some loud son with opening snap in the early case. As you know, in advanced cases, opening snap it's lost. And there will be some low volume pulse. In severe MS, there is a low. If the patient is having low volume pulse, it does mean the patient is having severe MS. That's not a simple MS or not a mild MS. The patient might develop some malar flash. So regarding the MRCP exam, malar flash doesn't actually mean the patient is having SLE. So if the patient is having a malar flush, you have to consider whether this is SLE, whether this is acne rosacea, whether this is a case of the mitral stenosis. Okay, so this is a case of mitral stenosis. Particularly if you think the patient is having malar rash along with having some dysphagia, so might be having also the left atrial enlargement due to the mitral stenosis, and that was the case in our mock session. Okay, so remember, I think 80% of the candidates they failed in this mock because they couldn't make the diagnosis. Sometimes there are some rare pathology or the rare association. How? Like they have given you what I should say, like in case of thyrotoxicosis or hyperthyroidism, we got a case of hyperthyroidism, but that was not a case of the hyperthyroidism. The presentation was the presentation of both the osteoporosis. So maximum candidates reached to the level of the osteoporosis, but couldn't find out the reason behind the osteoporosis. That was the osteoporosis due to hyperthyroidism or thyrotoxicosis. But as they couldn't mention the thyrotoxicosis, so somehow they couldn't achieve the full marks. Reason why? The result was something poor. And again, another thing, what I've seen in MRCP exam, I am discussing about the rare presentation, I must say. Okay, so don't panic, rather you have to be careful. Another thing what I have found recently, that another cause, that was the case of anemia, and maximum candidates failed to find out the vitamin B12 deficiency. So the patient had splenomegaly, but the doctor couldn't appreciate any organomegaly. The patient has had gross optic atrophy. Again, the candidate failed to appreciate the fundoscopy. Even some of the candidates didn't even ask for fundoscopy. Okay, so whenever you are suspecting a case with vitamin B12 deficiency, why you are only focused onto the subacute component degeneration as like the grade level student, okay, as you are in the post grad? So you have to think in that way. Go for fundoscopy, check the tongue, check the peripheral nerves, check each and everything, like the organomegaly. Okay, if you want to establish the vitamin B12 deficiency seriously. Okay, so you have to think in this way. I know you might say, oh well, these are the rare presentation. Again, I'm saying, please don't talk in that way. This is the MRCP exam. If I'm saying exam of the rare cases, no, it's not a wrong saying. Okay, I'm very authentic with my statement. Okay, so you have to think this way. So malar flush doesn't mean the patient is having SLE. It does mean the patient might have some mitral stenosis. So you have to look for the other features. Now, another thing, atrial fibrillation, that's the commonest thing. It should be on the top of the list. So features of the severe MS, length of the murmur is important, not the intensity of the murmur. An opening snap that becomes closer to the S2. That is the feature of severe MS feature. Again, the low volume pulse. That is also the features of the severe MS. Now, what would be the findings of the chest X-ray? What are the findings? There will be some left atrial enlargement. That would be the findings of in the chest X-ray. And echocardiography, what you will see? You will see the mitral valve surface area and the cross-sectional area, the normal cross-sectional area, up to 4 to 6 square centimeter. If you can see there is a mitral stenosis, then that should be less than 2. Some authors say there should be less than 1.5, and if it is less than 0.6 centimeter, that is a severe or tight mitral stenosis. So in severe mitral stenosis, the surface area or the cross-sectional area is less than 0.6, but it's 1 square centimeter here. But in PACES, you'll be asked the 0.6. If you are not saying the 0.6, they will keep asking you, are you sure? Are you sure? Something like that. But regarding the MRCP pardon, you can know that 1 square centimeter. Now, rheumatic fever is a graduation topic, so you have to know the major criteria, you have to know the minor criteria. Don't forget about these criteria. I mean the major criteria, we call it the CCPEMS. C for chorea, C for carditis, P for polyarthritis, and E for erythema marginatum. Okay, and EM for erythema marginatum, and S for again is for the subcutaneous nodule. So we're calling it the CCPEMS. Okay, so we might have some own mnemonics. Just go with this. Okay, so that's not a tough talk. The reason why I'm avoiding this, but of course that is important for the exam.
Now mitral stenosis or the mitral stenosis or the complication, the indication. This is, if I am saying this is a 10-star topic, even that's not a wrong talk. In everywhere you will be asked regarding mitral stenosis. What are the complications? What are the indications for the surgery? What are the treatment options? So we can consider PTMC. I mean, you know, the mitral valve commissurotomy or valvotomy, valvuloplasty, or sometimes total valve replacement. Okay, so we need to consider some of the cases. Now let me give you the idea when we will not go for surgery. Going for surgery is better. Again, I'm saying going for the surgery is better, but somehow you are now thinking, okay, I can consider something other than surgery. So then you have to have these criteria, like the patient shouldn't have any sort of, patient shouldn't have any sort of myxoma or any sort of thrombus. Number one thing, that is very important. The number one thing, the patient shouldn't have any kind of left atrial thrombus. If the patient is having any thrombus in the left atria, no, you have to go for surgery, not any other procedure other than the surgeries. Okay, so that's very important. Again, I'm saying, to rule out the thrombus in the left atria, the echo, the conventional echo we do run in our country, what we do, the transthoracic echo, no, that's not indicated. We have to do the transesophageal echo. If you want to see the atria, particularly the left atria, in MRCP way, you have to consider transesophageal, not the transthoracic. Again, I am saying never ever the transthoracic. Please forget about the transthoracic when you are considering, when you are dealing with the left atria. Again, I am saying, please. Okay, I am saying it 1,000 times. Please remember this thing. So we have to consider transesophageal echo. You have ruled out the patient is not having a any sort of thrombus in the left atria. Okay. So then you can consider PTMC or a valvotomy or valvuloplasty. Okay, that's fine. Again, the patient shouldn't have any kind of regurgitation issue. I mean, shouldn't have any leaking issue. So if the patient is having MS with MR, I mean leaking valve, again, so you cannot consider PTMC. Again, you have to go for surgery. Another thing, the last thing, and that is also important, the valve should be mobile. So if you think the valve is minimally calcified, okay, you can consider this procedure. If you think there is maximum calcification, the valve is totally non-mobile, so you have to go for surgery. So they are saying the valve should be minimally mobile, or there should be some minimal movement of the valve. Okay, if there is no movement, no, you cannot consider these things. You have to consider the surgery. Okay, so these are the things you need to consider before considering whether the patient is a candidate for the PTMC or valvotomy, valvuloplasty, or valve replacement. Okay, it will be asked, definitely it will be asked these questions. What about the mitral stenosis and the severity? Yeah, the severity of the mitral stenosis, there are some saying that like the significant symptoms might be pulmonary edema and episode of the pulmonary edema without a precipitating cause, pulmonary edema in pregnancy, pulmonary hypertension. So in hemoptysis, there are some saying mitral valve prolapse, it will come up with the features of the mid-systolic click. Again, a very important talk in the exam purpose. So what are the features or what are the causes behind this, or the associations of the that is associated with the, what are the conditions that is associated with the mitral valve prolapse? So the conditions most commonly that you need to encounter in the MRCP exam, and you have to consider the mitral valve prolapse. Number one, and that is the Turner syndrome. The number two, Marfan syndrome. So don't forget about the Turner syndrome. Don't forget about the Marfan syndrome. That's the first thing. The third thing, what you need to consider, that is the polycystic kidney disease. These three things should be in your hand. These three things should be in your head. These three things should be in your mouth. So don't never ever forget these three things: Turner syndrome, the Marfan syndrome, then the ADPKD. And if you can do all the things together, of course, also appreciate it. So what are the features? As I've said it, there should be a mid-systolic click if the patient squatting, and it would be late systolic murmur if the patient standing. That's the thing. So the patient will complain regarding the palpitation or the atypical chest pain, and the complication is that the patient might develop some leaking of the valve evidenced by the mitral regurgitation, or the patient might develop some arrhythmia, even some, as you know, mitral valve prolapse is another cause for the sudden cardiac death. Now the prosthetic heart valves. Okay, so before going into the prosthetic heart valve, I'll make it very simple, don't worry. So let me give you some of the questions. I think you guys asked me some questions and I have been given the questions here. So I am trying to give some of the answers from these questions, like what are the diastolic murmurs that based hard in the apex? Okay, if you are going to hear any diastolic murmur, of course that is the mitral stenosis, because mitral stenosis, the murmur of the mitral stenosis, it doesn't have any radiation. It's a fixed murmur. Another murmur, you have to be very careful, the aortic regurgitation murmur, regarding the MRCP exam. So if you have appreciated any diastolic murmur in the apical area, think about the MS at first. Then also think about the aortic regurgitation, because sometimes in the exam setting, murmur of the aortic regurgitation is somehow heard near the apical area or near the mitral area. Okay, so sometimes it will be very difficult, but for the pardon exam, MS should be your first priority if you're going to consider one in between this. Okay, what is the difference in between the diastolic and the systolic heart failure and the hypertension? Well, suppose a patient has come to you and the patient is having severe short of breath, leg edema, and on auscultation you can see the patient is having bibasal crepitation, that is even the coarse crepitations, and the patient is short of breath, almost cyanotic, the saturation is very low. But when you have checked the blood pressure, you have found the patient is having blood pressure 200 by 160, something like that. This is a hypertensive heart failure. Hypertensive heart failure. In a case of the hypertensive heart failure, the patient might have also some hypertensive encephalopathy. So check the flap. So check the space or orientation of the patient to check for the hypertensive encephalopathy as well. Okay, so this is the hypertensive emergency, as you know, as this is a target involving some target organ. And if there is a systolic, suppose the patient blood pressure is very low, so there is a systolic failure. Okay, there the patient is having a systolic failure. In MRCP exam, forget about the diastolic failure, forget about the diastolic thrill. Okay, forget about the diastolic thrill. There is nothing regarding the diastolic thrill regarding MRCP exam. Again, if you are going for the MRCP exam, as you are being the internist, not the cardiologist, so we don't have to panic with the diastolic failure here. Okay, so remember the systolic failure only here. How does trifascicular block cause PR interval prolongation? That's a different talk. I'll give you an idea, or just by doing ECG, that how bifascicular block and trifascicular block we consider just by from ECG. Okay, so forget about this thing here. Sir, can you discuss about the pre-systolic attenuation with the regard to murmur? Yeah, definitely. Why not? There are some pre-systolic attenuation, but this is a totally bedside learning. I cannot give you the demonstration here just by sitting. This is a bedside learning, so we have to go to the patient if I am going to make you, or I'm going to give you the demonstration of the pre-systolic attenuation. But I appreciate this question. This is a very important question regarding the patient's exam. So why does the severity of the mid-diastolic murmur of the MS doesn't increase the severity of the stenosis? Again, I'm saying the intensity of the murmur. The intensity of the murmur isn't the main thing. The duration of the murmur is the main thing. Okay. So if you think the murmur is very loud, no, it doesn't imply, it doesn't necessarily mean the patient is having a severe MS. Okay, it doesn't necessarily mean the patient is having a severe MS. Why? Like the patient is having a severe MS, but the patient is highly obese, so the murmur won't be that much louder. But if you are going to consider a murmur in a lean and thin patient, that even without having a severe MS, the murmur would be loud enough. Okay, so louder murmur doesn't necessarily mean the patient is having any severe issues. There's the questions, and thank you Dr. Warsala for the questions. You always keep asking some of the questions, and I think also some
There are so many questions that I need to answer, but I'm not getting enough time. But don't worry, I will give all the answers, because we have some printed copy like this, and you'll be answered. Don't worry about that. Okay, so I think you are happy now. Anyway, prosthetic heart valve issue. Okay, now let me give you a simple idea that who are the candidates for the bioprosthetic valves and who are the candidates for the mechanical valves. Okay, well, though there are some alternatives, there are some exceptions, there are some fallacies, but let me give you the simple data. Suppose a patient is having aortic valve disease and patient is almost 65 years. So as you know, there are two alternatives. You can consider mechanical valve, or you can consider bioprosthetic valve. So if you do think the patient is elderly, so you have to think that you have to go for, or it's wise if you go for bioprosthetic valve. Why? You know that bioprosthetic valve will have some longevity of around 8 to 10 years, and as the patient is already 65 or 70, so you know, so if the patient is having another 10-year chance to live, so that's better rather going for the mechanical valves. Why? If the patient is having mechanical valves, the patient has to take so many other things. I mean, anticoagulation. Even bioprosthetic, after taking bioprosthetic valve, the patient has to take anticoagulation, but not for long duration, for 3 months to 6 months. But in mechanical heart valves, the patient has to maintain a particular PTINR, the patient has to follow the yellow book due to warfarin, the patient has to take the anticoagulation for the long or the lifelong period of time. So you know, there are some disadvantages as well. Anyway, so if you're going to consider the bioprosthetic valve, that is usually a pork or any bovine in origin, major disturbance is that it doesn't carry a longevity. Okay, so that's the main issue. What's the advantage? The patient shouldn't take any long-term anticoagulation. You can consider the warfarin only for the first 3 months to 6 months, it might be extended. Okay, low dose aspirin is also is given long term. So definitely aspirin will be given to the patient for the long term. Okay, only aspirin is necessary. And in mechanical valves, the most common type of now implanted is the bileaflet valve. That is, the ball case valves are rarely used nowadays, and mechanical valves have a low failure rate. That's the advantage here. The disadvantage is that the patient has high chance of the thrombosis if the patient isn't following the yellow book strictly. Okay, so anticoagulation or enrollment with the anticoagulation clinic is highly necessary here. So the patient has to follow the target INR. What's that? If this is the mitral valve issue, so the target INR should be 2.5 to 3.5. If this is the aortic valve, then the target INR should be 2 to 3. Okay, so that's the main thing here. What about the tricuspid regurgitation? Tricuspid TR is a pansystolic murmur, we all know, and TR will contribute to the V wave, we know, and that will lead the patient to have a giant V wave in JVP. We have already discussed about it. In TR, the patient might have a pulsatile hepatomegaly that might be tender or non-tender, and left parasternal hip, not the right parasternal hip. It is the left parasternal hip. Okay, so there are some causes regarding this. COPD is the commonest cause here in our country. And some bicuspid aortic valve overview. That is the last talk of today's class. So what's that? As you know, as I've said it, regarding the MRCP exam, if you are going to consider any bicuspid aortic valve, think about Turner at first. Think about Turner again. I'm saying think about Turner syndrome at first if you're going to consider anything regarding the bicuspid aortic valve. So I call it the TVAV. Okay, T means Turner, VAV means bicuspid aortic valve, TVAV. Okay, another thing is TCOA, I mean coarctation of aorta. So somehow Turner syndrome is related with bicuspid aortic valve, Turner syndrome is related with the coarctation of the aorta. This is a common talk, it's not my mnemonic, this is a common talk, TVAV, TCOA. So Turner VAV, Turner COA. So around 1 to 2% of the population, you will see patient is having bicuspid aortic valve, and reason why a patient who is very young might develop aortic stenosis due to the previously or existing bicuspid aortic valve. So might be asymptomatic in childhood, but later on the patient might develop some problems that is associated, or symptoms that is associated with the aortic stenosis, ranging from short of breath to chest pain to palpitation to syncope or dizziness. So there might be some associated with the left dominant coronary circulation issue, posterior descending artery rest from the circumference of the right coronary artery here, Turner syndrome. Around 5% of the patient also have the coarctation. So as I've said, TVAP, TCO is associated somehow both together. Aortic stenosis or regurgitation as above, and high risk of the aortic dissection and aneurysm formation of the ascending aorta. That's why if you do think that any patient who has developed any aneurysm or dissection, and this is a posterior talk, so you have to consider Turner. You have to consider Turner, coarctation of the aorta, bicuspid aorta, in this way. But in clinically, we have so many other things as well. But regarding MRCP exam, you have to think in this way. Okay. So that was all from me today. If you do have any query, please tell me. And if you don't have any, I think if you enjoyed the class, we have talked so many things today that is important for the part 1 exam, part 2 exam, in PACES exam. And I hope you have already seen that we try to give you the idea that how you can pass the exam in part 1, in part 2, even in PACES, and that is highly needed for you guys. Believe me, whenever you will be in the PACES, you will see yourself, you are much ahead than the others. Okay, believe me. Okay, so if you do have any query, you can ask, or we can finish the class here. Cardiology, as I've said it, cardiology is the toughest thing and the very hard to achieve good number in MRCP exam. So please don't delay and don't keep the lessons, or don't keep your study for tomorrow. Okay, just be with the desk and finish your desk job regularly. So any query?
Sir, excuse me, I am from Sri Lanka. Hello. Can you hear
Sorry,
me?
sir?
Hello. Hello, I'm from Sri Lanka. Hello. Can you hear me?
Yes,
Hello?
sir. I can hear you, sir. Yes, sir. Yes,
These
sir. Now,
flow murmurs, these Austrian flint and grand steel murmurs were known as flow murmurs. How examiners assess how they ask us? I mean, in exam, in which way they wanted us to comment these
well,
murmurs.
now let me give you some idea regarding the flow murmur. First of all, in MRCP exam, if you are given a flow murmur, think about whether this is a benign murmur or not. First of all, think about whether this is a benign murmur or not. Okay, this is a very simple thing. No procedure is absolutely needed here. Just reassurances what the patient will need all about. Another thing, whether the patient is having anemia or not. In severe anemia, the patient might develop a flow murmur. That is a left western flow murmur that the patient might develop. Another thing. Third thing, I mean, if you're considering some pathological or more pathological issues, then of course you need to think about the murmurs regarding as you have asked, the Austin Flint, questions from the Austin Flint murmur or Gram-Still murmur. Well, let me give you some ideas, sir. In Austin Flint murmur, regarding the MRCP part 1 exam, they will give you the change deformity or the change of the murmur. They will say initially the murmur was best heard in this area after breath holding expiration, and the murmur was more pronounced during the early phase of the diastole. Now it is more on the mid or late phase of the diastole. So you know this is nothing but the Austin Flint. Okay, so this is how you will be asked. But what about the MRCP PACES exam? In PACES exam, nothing will be asked. You have to assess the patient, and suppose you have appreciated a murmur that is more on the late diastole, but that's not a murmur of the MS. So then you will have to say, yeah, I have some differentials. Might be case I have appreciated a mid diastolic murmur, so I have some differentials. Might be case of the murmur of the MS, or might be some Austin Flint murmur. Only then when you have appreciated a collapsing issue or bounding pulse or a wide pulse pressure or something like that. So question will be variable. I mean, question will vary like what type of the exams you're going to encounter. In MRCP part 1 exam, senior will be given. In MRCP part 2 exam, again senior will be given. In MRCP PACES exam, nothing will be given, only the patient will be there, and you have to assess the patient after checking the pulse and after osculating the precordium. Then you have to jump on the diagnosis. Okay.
Thank you, sir.
Yeah. Okay. So any other question?
if you don't have any other question, okay, so thank you so much for your patience hearing. Okay, we'll start the cardiology 2 in next week. And what I'm saying that you need to focus on the diet of the exam. I mean, you have, from now on, you have to focus that which diet you are going to sit for. Okay, so be very focus on that topic. Okay, so like you have to make your preparation. Okay, I mean, you have to make your own protocol for your preparation, and you have to know by yourself that when you are actually going to appear the exam. If you do think that you will take time, once you get prepared then you will sit for the exam, no, there is no definitive period that when you will get prepared. So it's high time that you have to think, yeah, this is my time when I will go for the exam, this is my time when I sit for the exam. This is how you have to think. Okay, otherwise MRCP part 1, it will be difficult for you to pass the MRCP part 1. So you shouldn't take much time to pass the MRCP part 1 exam. Okay, you have to take time to pass the MRCP pages, not the part 1 and not the part 2. Okay, so again, if you do have any question, please share the question in our Telegram group. We'll try our level best to help you guys. Okay, so best of luck, wish you all the best.